Good morning, commissioners. We are now live.
Good morning to everyone, and welcome to the first of our two meetings today on Market Oversight and Transparency Committee. We'll meet from 9:30 to 11, and then after that will come I can't ever remember the full name of the committee names, but the second will be 11 to 12. I always call them by their abbreviations. Will be from 11 to 12:30. So we have a sort of like fascinating agenda, which is not heavy on votes, but very big on digging into stuff today. And so our goal for today is to really dig in on the administrative complexity topic, and then to hear about and talk about our recent data points on flu vaccine administration. So that's where we're going today. I think first what we need to do is to approve the minutes from our previous meeting. And so Hannah, I turn it over to you for that. Is that correct?
That is correct. Thank you very much. Can I get a motion?
So moved.
And a second?
Seconded.
Great. I will start with you, Dr. Cutler.
Approve.
Commissioner Foley.
Approve, sorry.
Commissioner Mastrogiovanni.
Approved.
And Commissioner Kwasnick.
Approved.
Excellent. Thank you very much.
Fantastic. David, before we jump off, or maybe just as the part of that, I should probably turn over to David Seltz for any introductory comments before we dive in.
Thank you, Professor Cutler. Good morning, commissioners. Good morning, members of the public watching on our YouTube channel this morning. I think you set it up perfectly, Professor Cutler. As you said, we have a topic today that really we want to have some discussion around. Where do we go next on this project and on this work stream of reducing administrative complexity? What are the benefits of that? What are our policy goals? Where do we see some opportunities? So I think we can turn this right over to Cara Vidal or actually Kate Mills to kick this off.
Great. Well, thank you so much, commissioners, for joining us today. We're very excited to give you an update on the work that we've been doing on this topic and to get some feedback on other areas that we may want to explore. So I'm joined today by a number of different members of our team at the Market Oversight and Transparency team, as well as a member of our Healthcare Transformation and Investment team. I'm going to turn it over first to Cara Vidal, who has been leading a lot of this work.
Hi, good morning. Can everybody hear me okay? Great, wonderful. Good morning, commissioners. Great to be here with you today to talk about a topic that some have called boring, wonky, unsexy. And as someone who's been called all of those things myself, I'm hoping to defend against those charges and demonstrate that reducing administrative complexity without value is of real import to our healthcare spending, our healthcare workforce, and to patient access and navigation of the healthcare system. Commissioners, we've shown this slide before, and so I know that you know well that administrative spending is a huge portion of total healthcare spending in the US. Some estimates are as high as 34% of total spending. That's a third of our spending not going towards clinicians, not going to hospitals, not going to purchase drugs or devices, but instead is being spent on non-clinical costs. And a lot of this spending falls into a category called billing and insurance related activities, which is broadly understood to mean payer-provider interactions such as eligibility and benefit verification, referral management, coding, and billing. And all of these tasks are made more complicated and expensive in the United States because of our multi-payer system, where individual payers can adopt their own standards, rules, and procedures for completing the same task. Administrative spending is also one of the key explanations for why US per capita healthcare expenditures are so much higher than those of other high-income countries. We're spending just a lot more on these tasks than others are. So reducing the complexity in this area could lead to lower administrative spending, lower total healthcare spending, And even more broadly, it could lead to improved administrative processes that allow payers or providers to reallocate resources to higher value activities. It could help address the crisis of the healthcare workforce burnout, and it could help improve access, quality, and experience for patients. Okay, so with that table setting, let me pivot and tell you a little bit about the agenda for the rest of this discussion. So as David and Kate both mentioned, the board has a unique, or the committee rather, has a unique opportunity that we haven't had in several years to discuss where we should take administrative complexity work next. When we originally decided to make administrative complexity its own portfolio of work, this was back in 2019, we did a lot of stakeholder engagement with the HPC's advisory council, with payers, with providers, with consumer representatives, with commissioners. And the result of that was a decision to focus on prior authorization as a first topic area. That work was substantially delayed by COVID, but was sort of picked up again in 2021 and was sort of recently came to fruition in the form of a policy recommendation that we discussed at the committee meetings and the board earlier this year regarding automating prior authorization. So it's been several years since the board has had an opportunity to discuss what topics are of interest, what form this work might take. And so we're really looking forward to getting your guidance and your expertise on this area. As Kate mentioned, we have an all-star team today. We have Gina Della Russo, who was deeply involved in our prior authorization work. We have Mike Stanek, who leads the HPC's work on quality measure alignment. And we have Kathy Mick as well, who's relatively new to the HPC, but who brings excellent background and experience on several topics, including EHR interoperability policy. All right, so before I turn it over to them, I just wanted to briefly reorient you to the HPC's 2023 cost trends report policy recommendation on administrative complexity. So if we could go to the next slide. Thank you so much. Here you can see that this was a focus area in the cost trends report, and specifically there are 3 subcomponents to this recommendation. One is requiring greater standardization in payer processes. The second is automating prior authorization, and the third is mandating adoption of the aligned quality measure set. So before we kick off the discussion of where to go next in this work, we're going to have Gina provide an update on that second piece, the automation of prior authorization. And then following that, Mike will provide an update on the aligned quality measure set. So I'll turn it over to Gina.
Thank you, Kara. Good morning, everyone. Good morning, commissioners. So as Kara just introduced, one of our sub-recommendations is to automate prior authorization. So just as a little reminder, prior authorization is a utilization management tool that payers can implement. It requires that providers obtain approval for payer-identified services or procedures before a patient can receive them. And it adds administrative burden to providers as it requires knowledge of which services or treatments require prior authorization, something that's further exacerbated by variation in each payer's requirements, and it's typically done manually. And unnecessary complexity associated with prior authorization can also impact patients. For instance, patients can experience delays in care while prior authorization requests are being submitted and processed, even if their requests are ultimately approved. And automation of prior authorization removes the need for manual data entry and instead relies on electronic systems to identify if a prior authorization is needed. And if it is, it eases the process of submitting and processing that request. So our recommendation really calls on the legislature to build upon current national and state momentum and mandate automation of prior authorization processes utilizing a statewide roadmap with technical and financial assistance. And we can go to the next slide, please. Thank you. So our recommendation was really formed during our work with the Network for Excellence in Health Innovation, NEHI, the Massachusetts Health Data Consortium, MHDC, and the New England Healthcare Exchange Network, NEHN. And it would have the Commonwealth build upon a proposed CMS rule that requires all public payers to automate their prior authorization processes, among other things. And specifically, our recommendation would expand the requirement for automation to include commercial payers, create that statewide roadmap towards uniform implementation, and establish supportive structures that could include a stakeholder task force, as well as financial and technical assistance that would help move market participants towards uniform automation. And the CMS rule, proposed rule, was first published in December of 2022. Comments were accepted through mid-March of 2023. And as of today, the final rule has not yet been released. Thank you. So we recognize that automation is not a solution for all pain points that are identified in prior authorization, but this recommendation does have the potential for real-world process improvements. Automation could, in addition to reducing that manual paperwork that's required of payers and providers, help cut down on the number of prior authorization requests that are submitted. It could decrease the time from prior authorization submission to disposition. It could inform future reform efforts that are related to admin complexity. And notably, it opens the door for increased prior authorization program standardization to address the variation across payers in the Commonwealth. Next slide, please. Thank you. So even though that CMS final rule has not yet been released, nor has there been a mandate at the state level that requires automation of prior authorization, market participants in the Commonwealth are beginning work towards automation. So NEHAN, the agency that I mentioned earlier, provides online administrative solutions for payers and providers, and they've been central to this effort. And most Massachusetts-based payers currently do use NEHAN services, as well as a large number of our providers and provider practices. NEHAN is seeking to add automation to their current services that they provide, and further, the technology that they're looking to incorporate would have the potential to include other things beyond automation over time. This could include things such as quality measure data and equity data. And while this work certainly helps advance the Commonwealth towards uniform automation of prior authorization, it still relies heavily on voluntary participation of market participants. As long as some providers and payers do not participate, we can't achieve the full cost and time benefits that automation could provide. In order to achieve market-wide participation and fidelity to technological standards, legislative action is necessary. And I'll pause here for any questions before I pass it along to my colleague, Mike.
That was amazing. Can you just go back to a little bit more of the discussion of the CMS rule? And what is it that they need to write a rule for, and what do we know about the timing?
Sure. Oh, go ahead. Okay. So we know that it hasn't been passed yet. So there could be some changes that are made to it in the final release of the rule. But as we currently understand it, it's limited to public payers that, automation would be required. It also includes some requirements around what information payers might include in their prior authorization denials, timelines around when prior authorization would need to be responded to in an emergency situation. There's some language about improving data exchange, electronic data exchange, and calls for data reporting. So we are happy to stay on top of this and provide an update once the final rule is released.
But we don't need that rule to be finalized before we can do things. Is that right?
Yeah, no, that's right. And NEHAN, I think, is moving forward with the expectation that they will be able to design a process that's backward compatible with whatever that final rule is. In fact, they think they can even go a little bit further, address some of the concerns that stakeholders have raised about the standards for automation and even improve on them. But they've been very conscious throughout the process to make sure that anything would be backwards compatible. And of course, the release of the final rule will be really important in designing those final specifications, because as Gina said, they could change from what we've seen.
Okay.
And will the rule apply to both Medicare and Medicaid?
It applies to Medicare Advantage, state Medicaid programs, Medicaid managed care organizations, certain qualified health plans. I don't think it applies formally to traditional Medicare, although they have made some commitments to sort of studying and figuring out if they can adopt in that sector as well.
And I think worth noting on that point that many of our Massachusetts health plans are in the Medicare Advantage space or are Medicaid managed care organizations. So they are going to be working on this regardless if once this federal rule is passed. And so extending this to the commercial book of business is really an extension of work that they would already be doing.
Yeah, I think David, that's right. From my understanding, it's not so much the bigger folks because they understand that something like this is coming. It's sort of the smaller insurers that may not be aware, or the very, sort of odd insurers. Like, I have no idea if this is true in that case, but sometimes you hear strange things about like workers' comp programs and, sort of like small programs like that are sort of disproportionately difficult because they don't have that whatever scale to adapt it. Whereas when the rule comes along, then it's sort of like, okay, fine, we have to do this, so we're going to go ahead and do it. So I think the bigger folks are well aware of something like this coming.
And have any commercial payers agreed to work with NEHAN, or is that getting ahead of the process a bit?
So it's a great question. As Gina said, many of them already purchase many services through NEHAN. And so I think the vision here is that it will be another service available for purchase. Certainly, they've had a lot of engagement from the same payers who were involved in the task force that helped develop this recommendation in the first place. So conversations are certainly happening. There's definitely interest. So I think I would say, yes, they have good engagement. Exactly what form that takes, or whether there will need to be sort of resources for NEHAN to do some of the initial build and where those would come from, I think that's a little bit less clear. If there are no other questions on this update, we can turn to Mike Stanek to tell us a little bit about quality measure alignment.
Thanks, Kara. Morning, commissioners. I'm Mike Stanek. I'm an associate director on the Healthcare Transformation and Innovation team. For the next few minutes, I'll be talking about another policy recommendation for reducing administrative complexity, and that is mandating adoption of the state's aligned quality measure set. Just to provide a brief refresher on the background for this, in 2017, the Executive Office of Health and Human Services, in collaboration with the HPC and CHIA, convened a Quality Measure Alignment Task Force, which we generally refer to as the QMAT or the task force. The primary goal of the task force has been to propose an aligned set of quality measures for use in global budget-based risk contracts between payers and providers in the Commonwealth. One of the core rationales for this work is that widespread adoption of a single expert-informed set of quality measures would simplify administration for both providers and payers, as well as emphasize the state's quality improvement priorities and enable state agencies to better monitor health system performance overall. Members of the task force include individuals with quality measurement expertise from provider organizations, commercial and Medicaid health plans, academic institutions, state agencies, and consumer advocacy organizations. Through a consensus process, the task force develops and maintains the Massachusetts Aligned Measure Set, a standard set of quality measures and specifications that is reviewed and updated on an annual basis. The Commonwealth currently relies on voluntary adoption of the Aligned Measure Set by providers and commercial payers. Today, we'll be talking about the recommendation that use of the Aligned Measure Set be made mandatory in global budget-based risk contracts. Next slide, please. The composition of the Aligned Measure Set changes slightly from year to year as the task force determines if measures should be added or retired. Updates to the measure set are finalized prospectively in the late spring or the early summer for contracts starting January 1st of the following year. As is fairly common with these sorts of measure sets, the task force has defined multiple categories of measures, and I'll focus on the two most important categories. Core measures are those measures that payers and providers are expected to always use in their risk contracts. And menu measures are all other measures from which payers and providers may choose to supplement the core measures in their risk contracts. The 2024 Massachusetts Aligned Measure Set consists of 6 core set measures and 24 menu set measures. On an annual basis, CHIA, in partnership with the HPC, works with payers to collect a catalog of all quality measures used in risk contracts with providers. We use that data to track fidelity to the aligned measure set. And this is done by calculating payer-specific adherence rates that measure how frequently endorsed measures are used in each payer's contracts. An overall statewide all-payer adherence rate is also calculated as part of that process. You can see that statewide adherence rate over time shown here. Notably, there has been improvement over time, with fidelity to the aligned measure set rising from 65% in 2019 to 92% this year. However, it's worth noting that there is substantial variation across payers. Mass Health adheres completely to the aligned measure set, and some commercial payers come close to total alignment, while other payers have an adherence rate below 50%. With that in mind, getting to total alignment and reducing the variations between commercial payers so that we can fully realize the benefits of alignment will likely require mandating use of the aligned measure set. Additionally, compared to some other states, the Commonwealth's menu set is relatively large. The size of the menu set is reduced in the future to encourage greater alignment of contract terms in the Commonwealth. Maintaining the current statewide adherence rate might be challenging without a mandate. Next slide, please. Wanted to share a few examples of other states that have been leading in quality measure alignment. While a small but growing number of states have adopted statewide aligned measure sets in a manner similar to the QMAT, the 3 states highlighted here have used legislative or regulatory levers to require adherence to such measure sets. Rhode Island's Office of the Health Insurance Commissioner, or OHIC, has developed several measure sets for various provider types, including accountable care organizations. Through its affordability standards on commercial health plans, OHIC requires plans to adopt its aligned measure sets. And the state's Medicaid agency has also voluntarily committed to alignment with those measure sets. Minnesota's Department of Health has maintained a statewide quality reporting and measurement system for over a decade in accordance with a 2008 state health reform law. That system has a strong emphasis on public reporting, but it influences alignment in payer-provider contracts through regulatory requirements that prohibit health plans from requiring providers to submit data on measures that are outside of the state's standardized measure set. And finally, Oregon has also moved to align quality reporting using an aligned measures menu set, though only for publicly funded insurance programs like Medicaid, state employee benefits, and the state's health insurance marketplace. Measure selection within those programs is limited to measures contained in the state's aligned measures menu set. Next slide, please. Now, I did want to note one other related area that is of interest to the task force. The Quality Measure Alignment Task Force Charter identifies exploring options for systemized means for electronic measure reporting for use in value-based contracts as one of the intended purposes of the task force. One of the QMAT's goals recently was to identify current barriers to inclusion of electronic clinical quality measures, or ECQMs, in risk contracts and options for addressing those barriers in order to phase ECQMs into the state's aligned measure set. As you can see here, ECQMs are measures that are specified in a standard electronic format. They're produced and calculated with certified software right from EHRs. Their use does not involve manual processes like chart abstraction. Some of the potential benefits of using ECQMs identified by a work group of the task force included better population-based reporting as quality measurement moves towards greater use of clinical data beyond administrative data siloed by payer, and both improved metric accuracy and more timely reporting due to greater administrative simplification and automation. The group also explored the barriers to adopting ECQMs, which include inconsistencies in practice workflows and documentation practices for using the structured fields in EHRs, the multiplicity of provider EHRs, and also technical readiness for this type of data exchange. Some high-level potential solutions to those challenges that the group brainstormed were creation of a standard and automated reporting platform, consolidation of EHRs, and vendor support designed to meet the needs of ACOs. At present, the task force continues to have great interest in advancing the collection of electronic clinical data to reduce the administrative burden of measure generation. For 2024, it is recommended that if payers and providers are using the colorectal cancer screening metric in the state's menu set, that it be reported using ECQM measure specifications. This is in accordance with NCQA's reporting requirements for measurement year 2024. And while there's only one ECQM in the Massachusetts aligned measure set at present, there is intent to move in the direction of ECQM specifications for more measures in the future. Just to provide one more relevant example of a leading state, Rhode Island is an example of a state that has moved aggressively towards electronic quality reporting. That state, in an effort led by its own EOHHS and overseen by a public-private work group, has developed a quality reporting system to reduce provider burden by simplifying data collection, measure calculation, and data exchange for quality reporting purposes. The idea was to collect data once and create a single source of data to address reporting requirements of multiple payers and programs, serving as a central aggregator for multiple data sources, including clinical data. Rhode Island uses a vendor that serves as a data intermediary, collecting clinical data from provider EHR systems, claims files, and other data sources. Our understanding is that this is an ongoing project, with provider organizations continuing to work on implementation with the vendor, while Rhode Island's quality reporting system is working with the State Health Information Exchange to explore opportunities to leverage existing EHR interfaces to provide data. So we're interested in seeing how that work continues to develop. Thanks for your attention, commissioners. Before I hand back to Kara, I wanted to pause here and see if you have any questions on the last couple slides.
So Mike, is there any state that, of the three mentioned, are there any states that require all plans for all purposes to use a common measure set, and that common measure set is done electronically?
I don't think on the last point electronically is part of the requirements yet. And the number of states that have these kinds of requirements at this point, I think, is pretty small. Beyond the ones on that slide, I'm not sure there are many more examples. There are a few additional states that have aligned measure sets that are for voluntary use, similar to Massachusetts. But I don't know that anybody's at a state of having a measure set that's required and requiring full electronic reporting of it.
Is there a reason why? Like, is that where they're going, or there's some reason not to do that?
My sense is that it is where states are going. It's certainly where Massachusetts intends to go over time. I think there's just technical barriers that have made it sort of a slow process. But I think a lot of players are moving in this direction: NCQA, CMS, other agencies. So I think that is the future. It's just not clear exactly how long it'll take to get to full reporting on an electronic basis.
Okay, Tim, let me call on you.
Thank you. Hope everyone's doing well. The question that came to my mind based on the earlier presentation, as well as this, is do we have a assessment, or is there a conversation around the costs associated with moving to these systems, and who bears that cost, and also the impact on incumbent workers and future workers of like the training and how to get, how the implementation on the ground of some of these systems, so like the cost associated with it, because we know when folks move on to these systems, it costs significant amounts of money. And we know also, right, based upon work of this commission and others, that some folks have those resources readily available and others simply do not. And so how is that part of the conversation? Does it come up in these work groups of the costs, and how do you ensure that there's there's an approach that allows all providers to move to the system, or payers, and the impact on workers is kind of the two things that keep coming to mind for me.
Yeah, it's a great question. I think it does come up in the work groups, but I think this is largely viewed as sort of the next step in this ongoing decade or decade plus process of converting to EHRs. And so this is sort of the next functionality that these EHRs will require. And I think for a decade or so, there's been a lot of support and federal money and things for adoption of EHRs. I think that may have receded at this point. But at this stage, it's sort of, I think, viewed as more of an incremental sort of next step in terms of that implementation.
Yeah, I would also say there in the prior authorization space, the recommendation that we developed with NEHI and MHDC does call for financial assistance, exactly recognizing that point, Commissioner, and in particular wanting to focus any financial assistance that did come about to those smaller providers and those smaller payers for whom it is a much bigger barrier. I think your assessment is right on with what the work group what we heard in the work group, which is the bigger payers, the bigger providers already taking steps, already piloting in some cases, some of this technology, but it's often the smaller groups who find it to be a much bigger challenge. So I think financial assistance might be appropriate.
And Kara, in the work that we did with NEHI and some of the pilot programs, was any reflection on kind of workforce or the training or technical assistance in that space?
That's a great question. I know there was certainly talk about wanting to make sure that the technology could be implemented at different points in workflows so that people, if you want it to, in the prior authorization space specifically, if you want that to pop up at the point of a physician ordering something, it could also sort of be rerouted to back-end processes. So that flexibility, I think, is important. I don't know that we talked a lot about training for staff.
Yeah, thanks. Just think about like on the ground implementation, how it impacts folks day to day and what the workforce requirements would be or needed for the future.
Mm-hmm. Yeah, thank you.
David Seltz, this set of stuff seems like a good thing to also raise with the advisory committee in terms of, do people have any major objections? I mean, like, what do people think? Do they think, oh, thank God someone's doing this now, or, oh my God, we've had such a bad experience here. We need something different.
Yeah, I think that's a great idea, Professor Cutler. And I think one of my goals was, after this conversation today with the committee, is to bring some of these exact same questions to the advisory council at our next meeting to test with them. What are the areas that they see opportunity in? Are there barriers that we're not, maybe don't have insight into that can help inform it? So absolutely, I think part of the process here is getting your input and feedback, talking to the advisory council, and getting the perspective of people on the ground who are actually doing this implementation.
Anything else on clinical quality measures before we move on? We can always come back to this topic too, because we're now going to launch into, on the next slide, the final recommendation, and really the part of this presentation meant to foster discussion about other areas of interest, ways we might approach this work. So in fact, we can go right to the next slide. We're talking now about greater standardization in payer processes. And as I said at the top of the presentation, the US really is an outlier in terms of our complexity and administrative spend. And while there are many reasons for that, academics and researchers regularly point to the payer fragmentation that we have in the US. But one thing I think is really important to note is that having a multi-payer system does not condemn the US to always being an outlier in terms of administrative spending. There are other high-income countries that have multi-payer systems whose administrative spending is lower than ours. And that is in part because most other countries with multi-payer systems have a greater degree of standardization of those payer processes. That can include, for example, a standard set of billing codes, a standard contract or contract terms, standard list prices, et cetera. So increasing standardization in the payer process, we think, is likely a viable path forward for decreasing complexity and decreasing costs. And I'd like to throw out two concepts, commissioners, for your thoughts and reactions. One is that there are degrees of standardization, and there may be plenty of simplification effort and benefit that could accrue simply by moving down the path to greater standardization without having to get to a state of singularity or uniform strictly applied standards. And the second concept I'd like to throw out is that there are different ways to achieve standardization, and they don't all necessarily have to mean sort of developing a singular process and applying it prescriptively. And I can show you a little bit what I mean by that on the next slide. So really open to feedback and thoughts on both of those concepts. This is, a framework we've been working with internally, very open to comments and changes here. But here we're showing 3 ways we've been thinking about how you might achieve greater standardization. And let me provide a few examples, all in the prior authorization space specifically. So the first lever that we have on the left here is reducing variation and duplicative processes. So that's obviously the most straightforward one. And this might include, for example, calls for uniform medical necessity criteria that all plans would use in their prior auth, or developing, as Massachusetts has required in the past, standard prior authorization forms, for example. The second is leveraging technology. So here, for example, automating prior authorization. There are elements of standardization involved in that technological process. For example, developing uniform implementation guidelines that everybody would use, developing, as our recommendation includes, a roadmap for the order, the sequencing, the standards that you might use in implementing a new technology. And there's even been some discussion as to whether this initial inflection point where we're moving from a mostly paper-based system to a electronic system might itself offer opportunities for standardization. The example that has come up in the prior auth space is all payers have to have a set of rules that govern when they will approve a prior authorization. In order to move to automation, those rules have to be made digital, in a term that I have recently learned called a rules engine. And the conversion of those criteria into a rules engine is not a small amount of work. Is there opportunity to bring entities together to say, let's digitize it once, and then perhaps more people want to use that standard rules engine rather than having everyone go through that process individually? And then the third task here is simply eliminating low value tasks. Again, using prior auth as an example, there have been calls in other states and nationally to look, for example, at services that have very high approval rates, or services that may have been appropriate for prior authorization at one time, but due to changes in ordering or utilization or pricing are maybe no longer appropriate. Simply by really trying to encourage the elimination of prior authorization in those cases, assuming that the criteria are similar across payers, you get to a level of standardization, even if standardization itself wasn't the explicit goal at the top. So let me stop and see if there are thoughts or reactions on those ideas.
I think to me, that all sounds great. I think then the question is kind of, how do we apply that? Like, where are the prior authorization one, which you had mentioned, is really like extremely important, and just like this absurd example of waste. And I'm trying to think about broader, like, billing sorts of issues, and where would these fit into those sorts of tasks, or any of the other administrative tasks that we would like to streamline.
Great. Great. Well, let's move to the next slide then. And really, I think this is the last area of content we have before really just opening it up and hearing your thoughts and reactions. On this slide, you can see on the right a non-exhaustive list of areas of administrative complexity. We've shown this to you before, and certainly there are other things that can and should be on this list. This is just a partial list of areas. And then on the left, this is something we've been thinking about recently, having now had a few years of experience reading and learning about areas of admin complexity. Which are criteria that the HPC might want to consider when deciding where to take this work next. So there are a few things here. I'll just read them off quickly. The first is, what are priority areas for Massachusetts stakeholders? Where are they feeling burdened? Where do they feel like solutions are necessary? And is there engagement and priority to focus on them? What is the magnitude and the scope of potential benefits? I think we'd originally been thinking about this a little bit more narrowly in terms of dollar savings, but want to broaden our lens a little bit to time savings, complexity savings, navigational savings, for example. The third, going clockwise here, is the practicality of state action. And we may get later to some slides on EHR interoperability, a big area of federal activity and focus, some questions that we've raised on, is this something that a state really can do separately from what's already going on? HPC expertise, the need for new action. So lots of the things on the right-hand side of this slide are being looked at and worked on actively to various degrees. So where is there a gap in action, or does there need to be a gap? Is this, could the HPC sort of bolster existing work, support it, bring it, new resources or life, or even just report back to the board on what's going on with ongoing efforts. And then finally, impacted parties. So if there is, on the right, you've got magnitude and scope of benefits and, an assessment of who do those accrue to. And I think thinking specifically here about how important it is that there be some benefit to patients, whether that's monetary or confusion, time, frustration. So would love thoughts and reactions on areas, on criteria for consideration, and just generally your thoughts on admin complexity work at the HPC.
So let's open it up to either specific comments or broader comments. I have some, but I don't want to necessarily jump in front of folks if they want to jump in. But Tim, why don't you go ahead and then I'll come
Yeah.
back.
Yeah, not to kind of be a broken record or stick into my lane, but I just really, when I see a lot of the examples on the sidelines, I just think of job titles and hospitals and health centers across the Commonwealth and how we're engaging the frontline workers on this and kind of their experience and their ideas and suggestions for making improvements and changes, and talk to them how much time it takes to do these certain things, the patient navigators and the coders and everyone in between. So I just see a lot of voices. I guess it's the impacted parties piece where I'm really focusing right now, as we're trying to figure this out, like the impact of AI and all this too, and what role does that play, and what workers are going to be impacted by this, and maybe need to be trained and upgraded and skilled to do another job within the hospital. I think there's a lot of impacts on people that are doing the work, as well as the important goals of reducing the complexity, the cost, and the patient experience. Those are all important goals. And I think when we do that, there's going to be impact on some folks that are, a lot of folks that do this work every single day and both have frustrations with it themselves and fear about change within it. And so I think it's a really important piece of this conversation that I'll wanted to bring as we're talking about, very complex policy, wonky areas, of course, but there's both impacts on the workforce and the patients that we have to take into consideration. I know that we will, but I just want to kind of highlight that again as an important area for focus going forward.
Commissioner, what I haven't put up on the slides yet is our next steps, but certainly stakeholder engagement is right at the top of that list. So would love to maybe reach out to you for some help in having some of those conversations.
Happy to do it. That'd be great.
I mean, it's sort of, Tim, your comments are very well taken because, right, the transition is difficult. The transition is always difficult. And then on the other hand, we're just wasting so much valuable talent now as well. Just having people doing stuff where we don't need people to be involved. And it's like, you know, these are like very, very talented people who are having do stuff that's just not best serving patients and would be much better served if it could be serving patients better. So it's sort of, you wouldn't want to make it worse, but you also wouldn't want to do nothing on it too. So finding that is important. Finding that spot is important. Barbara, let me turn it to you. And as I say, I have comments, but I want to let others jump in as well.
Sure. Thank you, David. And just, you know, Tim raises a very interesting and I think critical point. When we usually go for stakeholder response, we tend to go to organized structures, into organizations. And when I think about our advisory group and I think about who they represent, some of them represent insurance companies, some of them represent policymakers, and some of them represent people actually engaged in the process. And so I wonder if how we get to the people that I think I hear Tim referring to is to actually look at a different way of seeking that input. Is there another way to get to the folks who are actually sitting there doing the work? You know, my experience in innovation tells me that the folks that know where the problems are and the folks that have the best ideas for how to solve them are the folks that are actually doing the work. And so how do we do that? How do we capture those folks, getting right down to somebody who's doing the data input, somebody who's actually doing the clinical changes? How do we think about that? How do we engage that group, which I think is the group I hear Tim talking about? So thank you, David.
I think that's very well said. So maybe I can just ramble for a few minutes because I'm not sure my thoughts are very organized. So if I can take the liberty of having the virtual microphone and doing that for a bit. So as most people know, this is a topic I've worked on a little bit. And I think what I want to do is talk about the money part, because that's the part that I've been focused on, not because the others are unimportant, just because that's the part that I feel like I understand the most. And a lot of this work has been with our old friend as a Nikhil Sani, who many people here know worked at the HPC at one point. I wonder, can I show one slide first? So I'm going to hijack to share one slide if I can.
I don't know technologically what needs to happen, but that'd be great.
Let me see if this works. Does this work?
Yes. Yes.
So as part of the work that Nikhil and I did, he's now at McKinsey. So we took, so we went through, you know, McKinsey works with a bunch of healthcare folks, and we looked through like, where is the money in administrative spending? And so it got put into the, we in the royal sense, put it into these 5 buckets. The biggest bucket of administrative expenses, this one in the bottom right here, which is what by McKinsey standards is called industry agnostic corporate functions. So those are things like payroll, HR, you know, basic stuff that every business has to do that are more expensive in healthcare than they otherwise need to be, given the size of the firms and stuff like that. That one's actually a very hard bucket. So that's things like, you know, the payroll system is less efficient in your typical provider office, and your typical hospital is a very poor way of organizing itself. And included in things like this are that, like, the website sucks, so that you have to have a million people on the phones, because like no one can even figure out where to go physically, what to punch in their GPS when you want to go to the hospital. So you need people to answer the phones and do that. But the one that we've been talking the most about is the one in the top left here, which is all the financial transactions. And so those are billing, and also prior authorization is going to go in there. So those are things related to like, how do you get paid for stuff? And so I think of the bucket that we're looking at here being the bucket which is billing and prior auth stuff. And that's sort of kind of stuck together in one sort of piece of my mind. In addition, there are other kinds of things like the quality reporting is sort of in the industry specific operational functions. So those are things that are specific to healthcare, like reporting on quality, which we don't have to do in other kinds of industries and stuff. Then you have a variety of customer and patient services and administrative clinical support. Let me leave those out because those are smaller. So the obvious bucket to me to think about is this sort of financial transactions ecosystem bucket. Let me now stop sharing and have you put back up the slide just so we can jump back to that. What you had said, which I think is right, is that the Commonwealth has gone down the road a reasonable amount on the prior authorization topic. And so, and I think that that is correct. We spent a fair amount of time on that. Thankfully, the Commonwealth has spent a lot of time thinking about that. And I think we've progressed to a point where we kind of understand what to do. And as a committee, what we should do is keep pushing where we are, pushing where others are, so that we move forward here. I think where we've made a little less topic, because it wasn't our first priority and where the Commonwealth has made somewhat less progress, is on the sort of billing, the transactions, provider A wants to submit a bill to payer one. And how do you go about doing that? In some cases, it's relatively straightforward because it's a big payer, big providers, they've worked with each other a lot. And in other cases, it's just totally messy because there are different rules for different insurers, and you can never remember whether the HMO plan from this organization with this specific company that's bought it requires the subsequent information on this other thing. Or even I've learned a bunch of things like, if you sometimes, because we're in Massachusetts, our zip codes start with 0, sometimes the 0 gets left off and then it gets rejected. And then someone has to retype the whole form, putting the 0 in the front so that it's, 02110 instead of 2110. And that can be the difference between, whatever, but that's a fair amount of money involved in that sort of stuff. And so to me, the thing that we want to think about is the streamlining of the billing and the operational stuff, both in the big payers, because nobody can quite remember exactly what, Blue Cross Blue Shield or Point 32 or Medicaid wants, Mass Health wants on these specific things, but also then the tail of smaller stuff. The smaller payers that you don't deal with very often, the smaller providers that have difficulty doing this. A lot of the people I think that Tim was talking about are people who are just insanely busy trying to remember these exact rules and the millions of Post-it notes about exactly how you have to go about doing it. And, the screen cluttered with, reminders about for this sort of thing and so on. And so I think we need to think about the streamlining of that part as being our next big thing. And to some extent, I think, so then the question is, can you do that on a small basis, or do you have to go somewhat larger to do that? Where larger is like a single portal through which things get submitted from any provider to any payer and back the other way. So that it's just sort of pre-populated. Okay, so fine. So every form can be pre-populated so that the leading 0 gets put on or taken off or whatever it is on the zip code, or, Massachusetts is always MA or, whatever it is, other, capital M, capital A, right? So the sort of the ultimate in standardization is, look, we're going to run a clearinghouse and you're going to use this clearinghouse and this is how it's going to work. And that's why I asked about the quality provider, the quality assessment, because that is like a clearinghouse. This is how this is going to work. You're going to submit this and then you're going to use it. And to the extent that that's the only way to do it, fine, that's the only way to do it. And then you decide you want to get rid of those administrative costs or not. Or the alternative is to say, no, we're going to try and streamline as much as we can. I'm somewhat skeptical about that path, in part because the tail of folks who are not doing it much is just really a lot. You know, the providers who don't do it much, and the payers for whom it's not done much, and the small plans for which they require something separate, and the small groups here that you have to do this separate thing for. Like, there's just a lot of, like if you think of the 80-20 rule, the 20 is huge here, if you will. And it's sort of disproportionately adding a lot to expenses. So my guess, although, you know, is that we're going to have to go bigger here as opposed to smaller, because the smaller just won't cut it with a lot of sort of one-off sorts of things, or, you know, very small off kinds of things. And I think that's sort of where we came to on the prior authorization, which is they're just going to have to be some rules. And that seems to be sort of where the world is converging. That's why I asked the question on the quality measures, because they're just going to have to be some rules, because we can't sort of do this streamline. And maybe on the billing process type stuff, we're just going to have to say, look, we're just going to do it this way. And there's just going to be no competitive advantage in, you know, do you spell MA capital M capital A, or do you spell MA capital M lowercase a, or do you spell MA 22 because that's the CMS code for Massachusetts, or, you know, do you spell MA, you know, in, you know, 17 because that's, you know, where it got labeled at some, you know, so we're just going to get rid of all of that stuff just by doing it in an automated way. So to me, I suppose that's the real question, which is, if we take that sort of billing part and we sort of say, is there a way to deal with it? Maybe the answer is, what we've concluded from past stuff is no, but we just have to say, we're going to move to a more centralized billing process, and this is how it's going to work. And therefore the EMRs will integrate with that, and they're going to, you know, everyone will install their software that then just puts things into that form, and that form is what's used. Anyway, so now I'm into peak rambling mode, which is because I'm teaching these days. But so that's where my thoughts are on this, which is the sort of one-off try and, you know, bang things here and there hasn't really done it. So maybe we need to just be broader here and say we can't be the police. There's too much small stuff here. We just gotta do it and just say, on these 3 or 4 things, prior auth, quality reporting, billing, there's going to be a standardized way to do it, and here's what it's going to be like.
David, please ramble more often.
You may be the only human being who's ever suggested that in my entire life. Deb, let me turn it over to you.
I'll second Barbara. So now you have 2. And the chart breaking down the cost was very helpful too. Just to follow on what you're saying, I think one of the things that would be very helpful to get feedback on is, do the entities that have been engaged in looking at administrative simplification, the plans and providers, do they believe that we've come to the end of what voluntary standardization can give us? You know, meaning I feel like what Dr. Cutler is saying is, in order to take the next step, we're going to have to require standardization. And my own sense is it's very hard to do that through voluntary means, because everyone has so many other priorities that are competing for the resources that it takes, that it's very hard to do that. But I guess my question is that consistent with what you're saying, Dr. Cutler? And also, what do other commissioners think about this question of voluntary movement to standardization versus requiring it?
Yeah, I think the voluntary movement has been much slower than anyone would have liked it to have been. And I think the point that Barbara and Tim were making, which is that going to the big folks is actually not even may not even be the biggest issue here. It's the tail of other stuff that's also that's not the big stuff that's really key here as well. Ron.
Yeah, what surprised me the most when we're looking at your slide, the 39% of just payroll and HR and things of that nature. And what entered my mind was, are the providers really motivated to take this action? Because I would think that would be something that they would want to do on their own, right? Independent of anybody else. When you're looking at what's referred to as the industry agnostic corporate functions. And that surprised me. So I'm just wondering, do we find that the large players in the business are really motivated to take action?
I'll just comment on this slide, and I don't want us to take this away from the other stuff. You know, I've done a little bit of asking, like, you know, why does your website suck? Like, why don't you just like make your website be better so you don't need as big a call center? And why don't you, like, you know, the examples that come up that, you know, the real back office stuff, like resume screening. Most big firms have automated resume screening, and basically very few hospitals have automated resume screening. And like, so therefore you spend a ton of time looking at resumes for things, whereas that's all automated in other businesses and stuff like that. And the answer seems to be, this is always fourth on our priority list. And every year we get to do two things on our priority list. And so this is always in the list of stuff that we'll consider again next year, but it never rises to the set of stuff that we do this year.
You know what the problem is in a traditional business? I can't imagine a CEO telling the board exactly what you said. Are you kidding me? Because those are dollars that would, for a regular company, would go to the bottom line.
Yeah.
So that's why I'm raising the issue. How interested are these large organizations in really making these types of changes? Because that's very surprising to me. I was stunned when I saw that number.
Martha.
Yeah, one thing I was just thinking about as you were talking, David, was so what are 1 through 3? And what are maybe the hurdles for them to clear off 1 through 3 in order to get to 4? Because I do appreciate the challenges that a lot of these organizations have with workforce and other things, which I think we would all agree are high priority things. And I'm wondering how to kind of think about that in relief against this. So maybe not a particularly helpful comment, but just something I was thinking about in the terms of trade-offs of, would we rather them focus on resume screening or, you know, updated charting or whatever the priorities are. Just throw that out there.
I think sadly, one of 1 through 3 is often like figuring out how to get more upcoding out of our EMR system. You know, so because we can get more money, you know, so which way is easier to increase the bottom line? Is it upcoding, or is it reducing the back office staff by having a better interactive system? And I think upcoding tends to win on that one.
I do think that's a great area for our future stakeholder engagement, though, or sort of what are the top 4 priorities for the organization, whether in the administrative spending space or more broadly in terms of dollar commitments. I think it would be helpful to understand that divorced from, you know, topic areas that we sort of pre-identified. I'd also like to just ask a clarification, Dr. Cutler. I'm familiar with the paper that comes from, but can you just remind us, that's not necessarily a breakdown of administrative waste, correct? That's administrative spending, and there's a separate breakdown of the categories where the waste levels are the highest, or are we looking at the waste levels here?
So that is breakdown of administrative costs. There's then a separate part, which is where we had tried to estimate how much could you get rid of using kind of stuff that's out there now that's commonly used.
And are the categories, do they rank in the same order, or does the order flip a little bit when you look at opportunity?
Let me show you another slide. this is like a professor's dream, right? It's like you're not even invited to present your work and you wind up like presenting whole papers worth of work. Like, what more could a human being want?
Just don't send me a bill from Harvard for this course.
So these were estimates of how much could be saved, where the bottom line number was 265 billion a year out of the $1 trillion that you started off with. The vast bulk of that was in these things that were what were called within, which is one company can do it on its own, or just working with one other organization. But the internal data management and the repetitive tasks and all of that, these are national estimates, not Massachusetts estimates, but that's the biggest part there. And so that's a lot of that bottom right bucket. But then you get the sort of other part, which is where you need to work between firms. And then the last row there is kind of where you need to standardize. What could you get by standardizing across all firms rather than just each pairwise sort of combination? So on a pairwise combination, you can do some stuff and then you can get other stuff if you sort of standardize. So, a lot of the money would be in the stuff that Ron doesn't understand, because like all the businesses that he deals with, like actually do all that stuff. But then there's there's still quite a fair amount in the, like, if you like streamlined between firms and across this space, either writ small or writ large, there's a fair amount of money there also.
Can I ask you another question while maybe commissioners are thinking if they have any more thoughts? To your point about the tail being long and the need to try and go after that 20%, because that's where so much of the complexity and difference arises. Do you think states are well equipped, given the number of programs and different tails that are not sort of at a state level authority-wise to regulate, for that to work at a state level? I'm thinking of the VA and TRICARE and Medicare and many things where even if we did build the ideal version of a centralized process, we wouldn't be able to require participation from many.
That's a very interesting question. I don't have a very strong view. I don't have a strong sense of the correct answer to that, or my answer to that, and I think it's worth exploring. I know that traditional Medicare actually has fairly low admin costs. There's not much prior authorization. The billing is reasonably standardized. Medicare Advantage has a lot of admin costs, but those are the insurers that we're used to dealing with. So we as a state see them a lot. And obviously Mass Health is something we have a lot of say over. So I don't know whether we need to take advantage of one of the CMMI, new things that they put out about state things, or whether we have enough authority now that we could try and do some of this. I haven't it's a very good question to ask, and I haven't thought about it with that lens yet. So David Seltz is saying that ought to be a topic that we can address. Let me see if anyone else wants to jump in on the administrative cost discussion. I think it's just hugely important, and technically very, very challenging, but just hugely important for us. Marty, yeah.
Yeah, it occurs to me that maybe the problem here is sort of the industry that supports the payers and providers, because they're providing legacy systems that require a lot of work and a lot of adaptation that ends up getting expensive. And I guess my point here is, I think we got to go deeper with the payers and the providers as to what they're working on and where they see opportunity here. Because, back to Ron's point, if I'm a good manager, I'm looking at all of this thinking, I've got to create some, better economies here. And I bet they, I'm sure Blue Cross and Point 32 have staff working on these very issues. And I think we need to really sit with them and see where those problems are, where the opportunities are, and what, to your point, what requires the standardized fix and what requires some just different thinking by these providers and payers as they plan these, these various operations.
Okay.
Thank you. I feel like we have a great set of topics to start and groups and perspectives to prioritize in the stakeholder engagement that I think we anticipate as the next big step here. So thank you for that. We had a few additional slides on specific areas of complexity. I think maybe it makes sense, given the time, to hold on those, to go back, do a little bit more research on them, and call it a day on this topic. Thank you.
All right, thank you. So let's jump to flu vaccine administration sites. At the end, there's going to be a quiz on who has received their flu vaccine for this year. So if you have, you will get a gold star.
Well, thank you. We're excited to preview today our next issue of our DataPoints, which is our online interactive research series. And we felt this was a very timely topic, as you said, Professor Cutler, to make sure that this is flu vaccine season. And we did some really interesting work just trying to understand, using our commercial claims data, about the shifting patterns of where Massachusetts residents are receiving the flu vaccine. So I'm going to turn it over to Diana, who's going to lead us through this presentation. Unless, Sarah, you wanted to kick us off.
No, you hit all the important points.
All right, great.
Turning over to Diana.
Great, thank you. Good morning, everyone. Good morning, commissioners. So yes, pleased to share with you today findings from our upcoming data points on sites of flu vaccination here in Massachusetts. And just a quick note to acknowledge one of our HPC summer fellows, Summer Rack, who laid the groundwork for the findings that you'll be seeing today. So thank you, Summer. And before we get into the findings, a little bit of background just about flu vaccines and their importance as a preventive care service. The CDC recommends that individuals aged 6 months and older should receive the flu vaccine every season. And here in Massachusetts, during last year's flu season, the rate of vaccination among residents was 63%, which was higher than the national rate of 52%. And flu vaccines can be administered in a variety of settings, such as doctor's offices, hospital outpatient departments, pharmacies, retail clinics, as well as mass immunization centers, such as stadiums, convention centers, and parking lots. And we'll be looking at these sites and these analyses today. But importantly, the setting of administration may have different implications for cost and access. Next slide, please. In this data points, in this analysis, as we've stated, we looked at the setting of administration as well as the cost for flu vaccines, specifically for commercially insured Massachusetts residents who got a flu vaccine between 2017 and 2021. And we did this using commercial, medical, and pharmacy claims within our all-payer claims database, or APCD. We looked specifically at individuals aged 3 to 64 who received a vaccine, and we do want to highlight an important limitation of this analysis, as on the bottom of the slide, that it only captures vaccines that were billed to commercial insurance. Individuals with commercial insurance may receive flu vaccines that are covered by other sources, such as work or school, and they may not be reflected in our data set. Next slide, please. And so jumping into the findings, we saw that most flu vaccines among commercially insured residents occurred in offices in 2017, indicated by the dark blue portions of the bars. However, by 2021, most occurred in pharmacies, indicated by the orange portions of the bars. And in our data points, as on the right-hand side of this slide, we do note some national trends. And while those are all payer statistics, and we're looking specifically at a commercial population here, they are good to keep in mind. Next slide, please. And when we look at the setting of flu vaccine administration by age, we saw that the shift to pharmacies was particularly large among commercially insured children and adolescents, as indicated by the dark blue and the orange lines here. And one factor that we think may be contributing to this are changes in policies here in Massachusetts in terms of the authorization of pharmacists and other pharmacy personnel to administer vaccines to children. So you'll see on the right-hand side of this slide, within the past 5 years or so, including during the COVID pandemic, there have been changes in the ages that pharmacists are authorized to vaccinate children at. Next slide, please. And in this data points, we also looked at flu vaccine utilization by income. So we see here on the left-hand side of the exhibit, trends among individuals living in the lowest income communities, and then on the right-hand side, trends among individuals living in the highest income communities. And we saw that prior to and during the pandemic, similar shares of these residents in the lowest income and the highest income areas got their flu shots in pharmacies. In 2021, 58% of individuals living in the lowest income communities did so, and then in the highest income communities, 62% of individuals. Next slide, please. And finally, turning for a moment to prices for flu vaccines. In medical claims, vaccines are often billed for the vaccine itself, as well as for the administration of the vaccine. And doing this breakout, we saw that while average prices for vaccines are generally similar across sites and have remained relatively stable over time, the price of the vaccine being indicated by the dark blue portions of the bars, we saw that administration costs appear to differ widely across sites, indicated by the orange sections of the bars. And in 2021 specifically, we saw that the average total price for a flu vaccine in a HOPD, indicated by the center set of bars, was double the price in other settings due to high prices for vaccine administration. And while we do see these differences in total average prices across settings, we do want to note here that flu vaccines are typically covered with no patient cost sharing, so may not be something that is immediately obvious on the patient end. Next slide, please. Great. And talking about 2021 and vaccines, we would be remiss to not talk about COVID vaccines as well. And so in this data points, as you can see here on the slide, we also looked at where COVID vaccines were administered among commercially insured residents. And we saw that most were provided in pharmacies, although more were provided in mass immunization centers than flu vaccines, with mass immunization centers indicated by the light blue portion of the bars. And we do include a note here on this slide that in 2021, there was, Massachusetts did have a phased approach to the distribution of COVID vaccines, where more of the population became eligible in April of that year. Next slide, please. Great. And before I go through the conclusions, we just wanted to talk about an important next step in our work, which is examining health equity and access to pharmacies as well, which is something that we'll be touching on within the data points. Within the data points, we'll be looking at access to pharmacies across the state by region and community income. especially because access to pharmacies in more rural areas can also be a challenge. This is important because we know that pharmacies can offer expanded hours, both evenings and weekends, or as well as easy booking and walk-in. And we're interested in whether this access is equitable across communities, with many indications suggesting it's not. And actually, there was a recent health affairs study that found that among major cities examined, there are fewer pharmacies in Black and Hispanic or Latino neighborhoods compared to white or diverse neighborhoods. And it also found that disparities were most pronounced in several cities, which included Boston. So just wanted to add in that point here before jumping into the overall findings as presented today, but something that we're keeping in mind for this upcoming DataPoints publication. But in terms of what we saw today, in terms of key takeaways, we saw that by 2021, most flu vaccines among commercially insured residents were administered in pharmacies, followed by offices and then by other settings, which is a dramatic change from previous years where most were administered in offices. And we also saw that an increasing proportion of flu vaccines occurring in pharmacy was observed among these residents of all ages and income groups, although particularly for children. And we saw that in 2021, the total average price for a flu vaccine in a HOPD was double the price in other settings due to high prices for vaccine administration. And a note here about the need for further analysis, keeping in mind the trends that we've observed here. So thank you for the opportunity to share with you findings from our upcoming data points. Happy to take any questions or comments.
That was an amazing change in where people are getting vaccinated. We find one much more convenient than the other. Any comments by commissioners? Maddie Castillo asks, any data on race, ethnicity on who is getting the flu vaccines?
Yeah, it's a great question, especially about that last point about differences in the distribution of pharmacies by neighborhood. Because we are using our all payer claims database data, there's not reliable race and ethnicity information within that data set. But it is an important question that we do want to keep in mind and perhaps include data from external sources that have been able to look at that.
Yeah, on that point, Diana, I suspect we may want to talk to our colleagues at the Department of Public Health who may have that information more readily available to complement our work here. And just to share my perspective, I was both stunned and not surprised by the shift into pharmacies. I think it tracks with the personal experiences of many of us, and I think a reflection of the kind of growing role and recognition of pharmacists and other pharmacy techs in playing an important access point for different types of services. And so something to continue to think about as we move forward.
I think it's really like a strong testimony to the impact that policies can have on access, that in pre-pandemic years, the minimum age was 9, and then to have a vaccine administered in a pharmacy, and then 3 during the during the pandemic itself under the sort of emergency period, and then raised to 5 now. But that, is such an important context in seeing the trends that we found.
All right, thank you. Okay, so I think we've reached the end of our agenda for today. And so David Seltz, do you want to just remind us of upcoming meetings, and then we'll take probably 3 minutes break between the 2 committee meetings.
Great. Well, I do want to highlight our big upcoming event, Wednesday, November 8th, the cost trends hearing. The registration is now live. We will have limited in-person availability for members of the public to attend. So if you're interested in attending this great event, please register as soon as possible. And in terms of upcoming meetings for this committee, I believe this is the last committee meeting of the calendar year, and that we will be back next year, early next year. We don't have the 2024 public meeting calendar set yet, but we'll have that soon. And I suspect we'll come back and be able to report back to this committee more on the administrative complexity work and other priorities. So looking forward to that. Thank you for a great discussion today. And Professor Cutler, I do think we'll actually have a few minutes in between the committee meetings for maybe the first time ever. So thank you for guiding the discussion.
I have failed in my most basic task, which is to keep everything late. Okay, great to see everyone.
Thank you, David.
Okay,
Great job.
thanks, everyone.
We're going to take a quick break and we'll be back at 11.
We are now live.
Thank you, and welcome to the next committee meeting of the CDT. Those of you who are
All right, Hannah, should we get started?
are we good to go?
Yes, we can continue with your
All right,
introduction.
I think we're ready to go, Andrew. Let us know when we're live.
I believe we are, David.
Hi, yes, we are live.
Okay, thank you, and welcome everybody to the meeting of the CDT. We have a very packed agenda today, so we're going to move quickly through the introductory work and get immediately to hearing the wonderful work of our two teams of guests. So without any further ado, may I have a motion to approve the minutes?
So moved.
Thank you. Is there a second? Okay, I'll second them. Are there any discussion or amendments? Hearing none, then those in favor of adopting the minutes as presented, please say aye. Aye.
Commissioner Blakeney, I think we need to do a roll call since we're remote. So I can take us through it. So I'll start with you.
Okay, thank you, Hannah. Keep me on the straight and narrow, and I say aye.
Thank you. Vice Chair Cohen.
Aye.
Thank you. Dr. Caskiel. She may not be.
I'm not seeing her on the screen, Hannah.
Yeah, she might not be back yet from the break. So we can circle back. I'm going to ask our designee from EHS, Amy Bianco, to cast her vote to approve the minutes.
I'm going to abstain as I was not here for the last meeting.
And Dr. McGregor.
Yes, I guess I'll have to abstain as well because I was not here for the last meeting, unless you're talking about the board meeting, which I was there for.
No, that's the right vote. Thank you for abstaining. And I'll circle back to Dr. Castiel now that I see that she's joined us again.
Yes, I'm sorry. I just joined.
You.
Thank you.
Thank you so much. All right, we can move forward. Thank you.
Thank you. And Alicia, welcome to the committee work. I hope you find it as enjoyable as I do. So we have approved the minutes and we are ready to move over. So I'm going to turn it over to Kelly for introductions and presenting our guests. Kelly, it's all yours.
Thank you so much, Commissioner Blakeney. So let me just say, we have been looking forward to doing a maternal health oriented care delivery transformation meeting for quite some time. So I think I can speak on behalf of many people when I say we are really looking forward to welcoming today's guest speakers who will be sharing insights from two really important bodies of work today. The first is the birth equity and support through the inclusion of doula expertise or beside investment program. And the second is INSPIRE, which stands for inviting narratives of SUD treatment in the perinatal period, a focus on race and equity. While these two initiatives are actually quite different, what they do have in common is a very, very powerful commitment to advancing health equity, something that is obviously a high priority in the Commonwealth. In addition, each of them represents an example of how to elevate the voices of people with lived experience, something that we've identified as a goal in our work as we work hard to bring an equity lens to all of our healthcare transformation work. So as Commissioner Blakeney said, this is going to be a busy agenda, so I am going to stop talking and turn it over to Taylor Bungo, an Associate Director on the HICTE team, to introduce our first group of speakers. Taylor, take it away.
Great, thank you, Kelly. I'm excited to set the stage for our first presentation from the Baystate team of the Beside program. As you may recall, Beside was launched in the fall of 2021 to address inequities in maternal health outcomes and improve the care and patient experience of Black birthing people by increasing access to and use of doula services. Our Beside program has 2 awardees, Boston Medical Center and Baystate Medical Center, and both programs are designed to increase the number of Black birthing people offered doula services, improve the quality of perinatal care, support a culture of mutual understanding and respect between doulas and hospital staff, and embed principles of racial equity and cultural humility. So we have the privilege today of Baystate Medical Center joining us, and they've used their Beside funding to set up a very successful new doula program in partnership with Springfield Family Doulas organization. And they're led by principal investigator and award manager, Dr. Nina Kesba, who has spent the last years at Baystate's Wesson Women's Clinic as their medical director, and recently transitioned to a new role as division director of family planning at the University of Connecticut. So Dr. Kesba, I'll hand it over to you.
Thank you so much, Taylor, and thank you so much to the Commission for having us today. We are very excited and proud to present our project. You can go to the next slide, please. So I have to acknowledge our amazing team. I also want to acknowledge Autumn Versace, who will be taking over as PI to see the Beside project through. Also Tanya Santos, who's our racial disparities health equity consultant, and also nurse midwife at Baystate Medical Center, our midwife consultants, Carly Detterman and Liza Winston, who you'll be hearing from later. And of course, our Springfield Family Doula team, Tina Council and Laconia Fennell. We also want to acknowledge our UMass research team with Laura Tanasio and Sarah Goff, who will be doing our secondary core measure analysis at the conclusion of our program, and the glue that keeps us all together, Laura Gebhardt, who's our program manager. Next slide, please. So our B-Side program is really comprised of 3 main goals. Our service-based goals were to provide doula services throughout the prenatal, labor and delivery, and postpartum periods. We also wanted to evaluate the impact of doula services on health disparities, increasing equity of birthing experience and maternal fetal outcomes. And lastly, wanted to evaluate implementation and feasibility of this new program. Our community-based goals are twofold. We wanted to engage efforts to expand the Springfield doula workforce through doula training for community members and re-engaging with individuals previously trained as doulas. And we also wanted to facilitate ongoing engagement with members of the Springfield community through community events to disseminate information about doula care. And lastly, we have the goal of sustainability to train additional community members as doulas and to create relationships between clinical and hospital leadership, as well as our local doulas. Next slide, please. Just to quickly review some of the evidence out there in regards to doula care and labor support. This comes from a large Cochrane review of 26 studies that included over 15,000 women. And when someone has continuous support through labor, it was shown that there was a 25% decrease in the risk of cesarean section, and the largest effect was seen when a doula was present. They also showed an 8% increase in the likelihood of spontaneous vaginal delivery, again with the largest effect when a doula was present. And from these 2 outcomes, the best results occurred when a birthing person had continuous labor support from a doula, someone who was not a staff member at the hospital and who was not part of their social network. Next slide, please. And as we know, there is a maternal health crisis, especially in regards to racial disparities. More women in the United States are dying from pregnancy-related complications than any other developed country, and that rate, unfortunately, keeps rising. In the US alone, women of color are 3 to 4 times more likely to die of childbirth-related complications, and their babies are 3 to 4 times likely to make it to their less likely to make it to their first birthday. In Springfield, Massachusetts, where we are based, the infant mortality rate is twice the rate of the state of Massachusetts. And according to some recent data in 2020, Black patients at Baystate experienced severe maternal morbidity at a 3 times higher rate than their white counterparts. And Hispanic patients had 2.5 times higher rate than white patients. Next slide, please. We do know, again, from extensive research that doulas reduce racial disparities in maternal care. In public health, racism influences social determinants of health, which include housing, education, and employment. And researchers have conducted interviews with racially and ethnically diverse, low-income pregnant women to try to understand how doula support may help disrupt negative social determinants of health. And researchers analyze women's responses around 5 main themes. First, they found that doulas play an important role in agency. And agency is defined as the capacity of individuals to act, to make their own choices. Doulas help their clients to understand their options and facilitated communication with their care providers. So their clients felt a sense of empowerment and ownership over their care. Doulas also contributed to feelings of personal security. And this also led to facilitating greater respect and autonomy in decision-making. Doulas also played a role in knowledge about their pregnancy, birth, and their birth process. And finally, doulas helped women with connectedness so they would not feel socially isolated. Many of the participants described stressful life situations and desired a doula with similar life experiences as someone who shared their culture and background. Next slide, please. From that same study, further describing a doula's role in reducing health disparities, low-income women of color reporting wanting but not having sufficient access to doula care, particularly those who identified as Black, African-American, or who are publicly insured or uninsured. Doula care can best match birthing people who are historically underserved, such as Black and African-American birthing people, families with substance use disorder, adolescents, or those impacted by stressors such as trauma and homelessness. And lastly, birthing people tend to seek out doulas who look like them and share their background. Representation matters in healthcare. Next slide, please. So kind of diving now into our specific program. The B-Side program launched in November 1st, 2021. We began enrollment on July 1st, 2022. We've reached our initial participant goal in February 2023, and we were very unfortunate to receive an award increase from HPC given our success to fund 20 additional participants. We have completed, as of recently, the recruitment of these additional participants and anticipate the final delivery to be in January 2024, with the program concluding in June 2025. Next slide, please. We feel that there was several key components to the success of this pilot project, one of which was the extensive preparatory activities that were done with staff and clinicians. There was 12 meetings that took place between May and June 2022. All types of staff, clinical and non-clinical, outpatient and inpatient, who would have interactions with B-Side and doulas. Our B-Side doulas and potential participants were included in these meetings. We introduced the B-Side program and the concept of what a doula is and could provide to promote awareness of our program. We offered to answer any questions from staff and clinicians and providers. We solicited feedback during these meetings as well, and we administered a baseline provider survey about their readiness to have a doula program at our institution. The other key factor was that all Baystate patient-facing OBGYN staff received equity training and cultural humility training provided by the Women of Color Health Equity Collective during 2021 and 2022. Next slide, please. In terms of our program criteria, we included participants who are greater than 18 years old, self-identified as Black or African American, express interest in participating, and who are currently pregnant before 32 weeks and 6 days of gestation. We did not include adolescents or patients planning to obtain abortion, fetal demise, or late entry into prenatal care. We also did include those that did not identify as Black. Next slide, please. Our recruitment sites included West Women's Clinic, Baystate Midwifery Women's Health Practices, as well as Mason Square Health Center. How we identified potential participants was that patients completed a race and ethnicity survey at their new OB visit, where they self-identified and self-selected how they would describe their race and ethnicity. All patients who presented for OB care, regardless of race, were provided information regarding B-side in our recruitment brochure, and the research coordinator contacted and screened eligible patients who had expressed interest, and the Springfield Family Doulas provided a doula care for our program. Next slide, please. This was just a slide to summarize what our doula care program looked like. We offered 4 prenatal visits between enrollment and delivery, and had the options of meeting participants in their home or at a mutual site or on the clinical site. During labor and delivery, continuous doula support from the onset of active labor until approximately 2 hours postpartum. And then in the postpartum period, between hospital discharge and 8 weeks, to have at least 2 points of contact. Next slide, please. So in terms of our recruitment, we received 918 race and ethnicity surveys. Of those, 200 self-identified as Black or African American. 114 expressed interest in the B-side program. We consented 54. And as of this data of last month, 54 had consented and 31 had completed the program. Next slide, please. In total, there's been 127 prenatal visits by our doulas, 25 postpartum visits while in the hospital, and 48 visits in the postpartum period after hospital discharge. Next slide, please. In terms of the neonatal data through September 1st, we had 20 vaginal deliveries, 13 C-sections, and 6 preterm deliveries. Next slide, please. We had 9 NICU admissions during the delivery mission, 2 NICU readmissions within 28 days, 0 instances of severe maternal morbidity at 6 weeks postpartum, and 0 maternal readmissions between delivery and discharge and 8 weeks postpartum. Next slide, please. Describing the experience and readiness of our providers is a secondary goal of our program. We did a provider involvement and we elicited provider involvement and feedback through a baseline survey. We had emailed following the initial B-side introductory presentations that I previously described to gauge familiarity and experience and readiness for a doula program. 76% of providers reported having had a positive experience with doulas. 37.5% of respondents indicating having at least one negative experience with a doula. Most cited doulas' interference with medical advice, making it difficult for the health professionals to build a trusting relationship with a patient. These results are consistent with prior studies regarding mixed attitudes towards delivery, towards doulas among labor and delivery nurses, midwives, and obstetricians. So we knew from previous research and this baseline survey that there were some implementation barriers potentially and some resistance that we may encounter during our program that we had to address. Next slide, please. We did do a follow-up survey of providers at the 1-year mark. It was emailed in August 2023. It gauged if and how receptiveness to doulas and the B-side program had changed over the year. Results are still being analyzed, but these are some of the quotes that we pulled out from providers. For example, one of the midwives said, "We really need more doulas. Our low-income Latina patients could really benefit as well." A physician responded with, "Would love for it to be expanded to increase access to more patients' practices who would likely benefit from the added support." Next slide, please. At this time, I wanted to pass off the microphone, if you will, to Carly Detterman.
Thanks, Nina, for that great overview of our program. I'm Carly, and along with Liza, we were the doulas collaborators and liaisons. We are both certified nurse midwives who are advanced practice nurses trained to take care of folks throughout the reproductive lifespan. And midwives have always had a holistic patient-centered approach and historically have valued a focus on health equity. So we were kind of perfectly poised to serve as kind of a go-between between the doulas and the hospital-based staff. So we have fortunately been working with Tanita and Laconia before this grant started. They teach labor support to our midwifery students. And we've shared patients over the years, so we already have had a relationship with them. So when the grant started, our role as midwives was to orient the Springfield family doulas to the Baystate system, to act as a liaison between the doulas and labor and delivery staff and administrators to help them troubleshoot concerns and to help our hospital team troubleshoot concerns and to perform regular check-ins, basically serve as a bridge between the doulas and the medical folks that we are working with. Next slide, please. So in terms of orienting the doulas to Baystate and orienting Baystate to the doulas, before this program even started, Liza and I were really interested in bringing doulas to our hospital because of some of the reasons we've cited before, including reducing health or increasing health equity. We had sponsored a grand rounds with Christina Gable, who is a birth doula and does a lot of public health work with doula initiatives. We had collaborated with the doulas to create a presentation to introduce the evidence behind doula care and also the doulas specifically to everyone who is going to be interacting with the doulas. So that was very helpful. We also needed to help orient the doulas to what we affectionately call the medical industrial complex, which is just the way things work when you're working in a big hospital system. You know, just in terms of getting all your competencies done and getting your flu shot. The doulas are, and I'll let them talk more about their business, but they're an independently run business who served as they worked in a contracted relationship with Baystate. So we had to kind of sort through what that meant for the way that they work and the way that we work together. Next slide, please. So the other thing that we did is made ourselves available 24/7 to the doulas as they were getting used to working more regularly in the hospital system. Now, both these doulas have attended private patients in labor at Baystate, but to kind of be more integrated in the hospital system, we wanted them to have support people that they could touch base with if any concerns came up. So they're able to page us, you know, if they need anything at birth or if afterwards, if they needed to debrief in the moment. And we also had a more formal debriefing system that I'll talk about in a little bit. Some of the concerns that would come up in the moment is they might have an interaction with a patient who is feeling like they're not getting what they need from the healthcare team and helping them navigate that kind of from both angles, from the doula angle and then from our angle. If a patient, say, was having a hypertensive crisis at home and not hearing back from the provider, we were able to contact the provider and make sure that that was happening. We many times got pages about the doulas not being seen as part of the healthcare team. So either asked to step out of the room or not being let into the OR during a C-section, which is a very important time to have your doula with you. And so just kind of making sure that everyone was on the same page about, making sure that our patients had continuous access to doula care and that the patients were also getting what they needed. Liza, who I don't think is on this call, but she works a lot with the residents. And is on the labor floor a lot. I'm there just when I'm on call. So we were able to kind of just keep our ear to the ground and hear what was happening in real time and be able to step in and help navigate some of the more tricky situations that come up when you're doing something new. Next slide, please. I love this picture so much. I just had to include it. It is a picture of Tanita and Laconia teaching our midwives labor support. And so in addition to kind of the informal feedback, we had after every birth a more formal feedback about how things went. We gathered data that we put into our data gathering system, RedCaps. And also at the end of every month, we did a check-in with the doulas, a more formal check-in to both gather data and kind of figure out themes of things that were reoccurring that we had to look into. Next slide, please. I think Tanita and Laconia are going to take over now, and they can talk just more about what the experience has been like for them. So I turn it over to you, Tanita and Laconia.
Hello, good morning, everyone. I am Laconia. Here we go. Awesome. I'm Laconia, one of the doulas from Springfield Family Doulas, and Tanita is here as well. We are both doulas, and we're co-founders of Springfield Family Doulas. Just one of the reasons why we kind of came together and formed Springfield Family Doulas, because we noticed and seen a need for our community, the people around us that needed more support and education around birthing when it's time to birth and be pregnant and postpartum care. So we formed Springfield Family Doulas. That's a little bit of background of us. Next slide, please. So these are just many pictures of what we've been doing with the Baystate midwives and within the B-Side Doula program, increased connection between doulas and midwives. Like Carly had said, we were able to teach labor support process to the midwifery students. I believe this is our third or fourth year of doing that. We also were at, for Black Maternal Health Week, we were at Baystate, and Tanita was on the panel just sharing her voice on the experience of being a doula and supporting Black mothers, but also being a Black mother and being in that space and how that felt and what her experience was as well. Next slide, please. So myself, during this B-Side Doula program, I was able to be trained as a prenatal yoga teacher. I've also continued the Baystate onboarding activities. And I'm in the process of finishing my breastfeeding educator certification, which is super important because we've noticed that women struggle at home a lot when it comes to breastfeeding and trying to figure out what to do. So we felt that was a need, and thank you, B-Side, for allowing us to take that program, and also train the trainer certification. We feel like more people do want doulas, and I feel like we need to have more trained doulas in our community to provide that service. Tanita as well has been continuing Baystate onboard activities. She's also in the process of finishing her breastfeeding educator certification and also the train the trainer program. Next slide, please. So this is a picture of us at one of the community outreach events that happened, and we love going there because we love just talking to the people, seeing what their needs are and adding those to it, like we said with the train the trainer and the breastfeeding education. So we get to really talk to our community and they tell us what they need. So it's awesome to be able to do that. From May 2022 to July 2023, we participated in 18 community events, really promoting doula services, promoting the B-Side project. And some of those events included health fairs, community baby showers, Black Maternal Health Week, Juneteenth Jubilee, and breastfeeding awareness. Next slide, please. So a little bit about what we kind of encountered during this time at the hospital. evolutions of interactions with clinical staff, clinical and administrative staff that could include nurses, doctors, front desk staff. At first, we received a little bit of pushback or a lot of pushback and hesitation and felt the sense that we were on opposite sides. But as the staff became more familiar with us, they were watching what we do and became familiar with how we interact with our clients. It became more cohesive, the client and their healthcare team at the time. So that was a great improvement. Important factors in building positive relationships between doulas and hospital staff. We feel like education about the role of a doula as part of the hospital could be helpful as part of a hospital orientation. The nurses learn the roles of a trained birth doula. I think that would help them understand us and our part in the hospital. Also, attending workshops together can facilitate relationships, building respect, trust, and communication. Next slide, please. So the effects of shared identity between doulas and clients has come up a lot with our clients, even our private clients, but it's just that it really helps clients overcome fears about how they might be treated or mistreated within the medical system. Opportunity for a woman to show up with you that already identifies with you. A lot of women said, I need somebody that looks like me. I want somebody that identifies as me. So that's one of them. By identifying with clients and acknowledging their experience, Black doulas can create a space of trustworthy. So once the clients feel like, okay, you're familiar, you have a familiar face, you look like me, we've been through things together, it eases their stress level and anxiety once they are in the hospital. We have several clients that state, thank you for looking like me in the hospital that is filled with people that don't look like me or come from where I come from. And we thought that was that stood out, but was very common amongst the women that we served in this project. Next slide, please. Connecting with patients support system. So this picture here is of a mama, her third pregnancy, and her husband here supporting her. And before she was in labor, one of our prenatal visits has to do with comfort measures, and we asked the support person to come. So they were able to learn it, and once she was in labor, they were able to kind of kick in and do what we taught them. So including the support person, it could be a partner, a parent, an auntie. We've had grandmothers in the prenatal appointments. Also teaching the support person comfort measures and helping partners become more engaged. That was another thing that came up with our clients, was like, I want my partner to be engaged. And also the partners were very interested and wanted to be more hands-on because they were like, I don't know what to do. So that was that. Next slide, please. Sustainability. So met with the Baystate strategic planning, continued to identify potential internal and external funding for future doula programs. Select preferred doula model. There's several different types. There's the Baystate employees, there's independent contractors, and we've had discussions of pros and cons with existing doula companies. Springfield Family Doula applied for the Massachusetts Attorney General's Health Equity Grant Program, and it was to hope to secure funds to train new doulas as well as fund training to become parent educators. And doula workforce development. The doula train the trainer and train additional doulas. I think, do I go back to Carly? Maybe?
I think so we will end our presentation there. I think as stated in the beginning, the meeting has a really full agenda, and we hope to leave a couple minutes for questions from all of you.
I have a question if this is the moment for it. So
of course.
Okay, wonderful. So first of all, thank you so much for that presentation. This is excellent, and it's so encouraging to see this work taking place. My questions are around payment and also around C-section rates. So first, I think in the presentation by Nina, you mentioned that in terms of mode of delivery, I think you said that there were 20 vaginal deliveries and 13 C-sections among the first group. I can't remember if those were the numbers, but if those were the numbers, that seemed to me a little bit higher than I would expect, especially with a doula present. So I wondered whether you thought that the patients who opted into working with a doula might be patients who were intending to deliver via C-section anyway, or have the C-section rates been high at Baystate recently? I'm just curious as to why you think that was the case in this among these initial participants. And then the second question I had was around the rates that doulas are paid through the program, and how does that rate compare to what is being considered in the proposals for Mass Health reimbursing for doula care? Is that rate more or less? Because I know that's something that commonly comes up around the country around with respect to doulas, especially working with I don't know if so you said it's all Black birthing folks, but is it potentially among low income populations? I know that there's a lot of pushbacks from doulas regarding low rates, and that those rates being way too low to be sustainable. So those are my questions for now. I think this program is obviously doing wonderful things, and I think helping to kind of especially work out the kinks between that hostility between existing providers and clinical staff in terms of accepting doulas into their space. That seems to be one area where I think it looks like we need some more progress, and it looks like you all are helping to get us there. So thank you so much.
I don't mind answering the first part of your question, and then I want to hear what the doulas thought, because I have thought a ton about our section rate, especially at the beginning. I thought, like, every birth, I'd be like, another C-section. Like, in my midwifery brain, I thought that this intervention was going to decrease the section rate. And then I kind of had to just do a pivot and think, if the reason, everybody had a great reason for why they had a section, and we can get into the data at some other point. But what I thought is this grant is really actually doing its job, in that it's reaching the people with the highest morbidity and mortality risk, and getting them extra support. And I think we don't have this data, but in the narratives, the folks who were having that like reason high morbidity risks that needed the C-sections felt empowered and listened to, and like they were making the choice to have the C-section when the C-section was needed. They didn't feel like the medical community was telling them, like, you're in terrible risk, you have to have a section. So I had to do like a big switch in my brain and understand that as a midwife, my goal is to, of course, decrease the section rate, but as a public health initiative that's going to decrease health disparities, maybe that's like not the number one goal that we should have. I think it just showed that the grant was doing its job, and we were getting care to the people who were going to have the highest risk births. When you look at the reasons for the section, and when I look at them, I think they were all like completely justified, and that's how I come at this. And I'm interested to hear what Tanita or Laconia has, because they were in the room with all of these folks. And then they should answer the second part about the reimbursement as well.
Yes, so I believe that the C-section rate was a little on the high end too. But as a doula, we are non-medical professionals, so I can't really speak on like that medical part. But what I can say is kind of piggyback a little bit on Carly, is like being informed about it before it happens. Of course, we had a couple of them that were like an emergency and needed to happen right then and there for the safety of mom and baby. But there were other ones that were like brought up early because there were signs from the medical professional. So it was nice to have that brought up early and then to be able to like push it off until there was a sign that was like, okay, we're going towards C-section. So I think the clients, I mean, nobody wants a C-section, but I think the clients were a little bit more comfortable with it, with us supporting them through that. And then being in there in the OR when we were able to be in there, sometimes it was just a mess. I hate to use the word a mess, but sometimes it was not, we weren't allowed in or whatever sometimes, but just being in there made a big difference. And then also being in PACU, once they do come out of surgery, made a big difference on their C-section. We've had a client that was her second C-section. She was trying for a vaginal delivery, but ended up having a C-section. But the C-section was so much better because she had support from a doula. With the other C-section, she had nobody there. So it did make things better, and it improved her postpartum care. So I think it's helpful still when they do have C-sections. For the mass health, what was your question? Okay, for the mass health question, I'm not sure. I think it's a little bit lower. The mass health reimbursement is a little bit lower. And I think it's probably too low, and maybe they'll go up a little bit, but I'm not sure if it's set in stone yet, because they still have holding like listening sessions and things like that to finalize everything.
Okay, thank you so much. And what you both said about the appropriateness of C-section resonates a lot with some research that's now emerging. And actually my research team, we have a paper that hopefully will be published any day now, that where we found in New Jersey that for Black women, those who were low risk for C-section, meaning they didn't have any indication in their medical record that they should need a C-section, those were the folks who were more likely to receive a C-section, so an unnecessary C-section. But for the Black women who were higher risk, meaning they had some indication that a C-section might be appropriate, they were significantly less likely than other groups to get a C-section. And it was really only among Black women that there was this misalignment in care. So the problem of missed opportunities for C-section is something that I think is coming up a lot in the evidence. So it sounds like doula care is helping to sort of align appropriate care in this case, because it sounded promising that there were no cases of severe maternal morbidity in the end. So that sounds really wonderful.
I think we have time for one more question before we move on to our next group. And I want to make sure that we get that opportunity. Are there any other questions?
Barbara?
Yes, please.
Yeah, wonderful presentation. I think really, what you've done is you've turned around a culture in a hospital, which is not easy to do. So congratulations. I guess my question is, as the grant winds down and you're looking at your sort of last delivery coming up in January, what do you see as the future? Is there, and as the grant ends, hopefully Mass Health will provide reimbursement for doulas, but sort of I'm curious as to the sort of organizational change within the hospital, and whether you see that continuing past the end of the grant.
Yeah, I wanted to invite Dr. Versace. Do you want to respond?
Sure. Thank you for the question. We very much want these services to continue after the grant ends and the pilot closes, and we're looking at several areas when we consider that future state. So the first is funding, which we've touched on a little bit, and looking not just at the Mass Health reimbursement question, which is quite promising and needs a lot of a lot of our focus and attention, but also other internal and external funding sources to enrich the sustainability of a program like this. And as Laconia mentioned, there's a decision point regarding the preferred model of doula staffing, if you will. So either, you know, system or Baystate employed versus independent contractors that work in partnership. And there are definitely pros and cons to each model that we're carefully considering. We also talked briefly about funding from the AG's Health Equity Grant Program. And the hope is that that funding can help to build workforce by helping to maybe train more doulas and also to enrich the services provided by the doulas, you know, for example, for them to become parent educators. And then, you know, finally, workforce development is a huge cornerstone of the sustainability of the future of a program like this. And so Laconia mentioned the Train the Trainer program, which we've initiated, I believe, with 2 or 3 initial trainees. And, you know, we recognize that as we look forward to trying to figure out how to make a pipeline for that workforce in our area, we need to consider, you know, both what's acceptable to the community, what works for the doulas, and also what is hopefully in alignment with the pending Mass Health requirements for doula certification for reimbursement. So those are the 4 areas that we're focusing on.
Thank you.
Thank you so much for this presentation. I just want to acknowledge the hard work that you've done. As Marty said, you're in the process of changing the culture of the hospital. And that is never, ever easy. Changing the culture of the healthcare establishment, which is rooted in tradition and rooted in strict rules and roles and procedures, is always a challenge. What we're looking for was to use this as an opportunity to discover and to measure more strategically what impact doulas had on providing care to low-income patients. Doulas traditionally in the past have been involved in providing care to those who are financially able to fund a doula. We recognized that needed to be different. We recognized that there's a growing number of folks who have a tendency to be high risk because of social determinants of health that we wanted to address, and we wanted to see whether this kind of a program could make a difference. That's the basis behind this grant, and it's part of the important work that we do, not only in terms of the funding opportunities, but looking at innovation. So thank you very much for helping us get to some preliminary answers to those questions. We appreciate your efforts, and we know how hard you've worked. So thank you. On behalf of the commission, thank you very, very much. Kelly, I'm going to turn this back to you to introduce our next group.
Thank you so much, Commissioner. And thank you again to our colleagues at Baystate. Every time I hear about your work, I'm just really, really inspired, which is a nice transition to our next agenda item, which is about the Inspire program. Unlike the Beside program, this is not a traditional HPC investment program, but instead is a really, really valuable partnership around areas of common interest. And I'm not going to say too much more about that, but I am going to hand off to my colleague, Molly Sass, the manager of our C4SEN program, and also our liaison with the Inspire project, to introduce Inspire very quickly and to welcome our guests. Molly, take it away.
Thanks so much, Kelly. Good morning, commissioners. We are very excited to welcome Dr. Davida Schiff, Julia Vasquez, and Tisha Gulo, who will discuss the Inspire project and how that research is informing the family engagement project among a cohort of 5 hospitals. As Kelly mentioned, the HPC has supported this work through a partnership with DPH and the Perinatal Neonatal Quality Improvement Network, with funding through the State Opioid Response Grant from SAMHSA. Davida and her team have been a wonderful resource for the Healthcare Transformation and Innovation team, sharing insights and strategies as we approach investment programs and ensuring that the patient voice is part of the force that guides our program design and shapes our program evaluation through the investment in patient experience data collection. Today, they will discuss the Inspire project purpose, design, and initial findings, and will seek feedback on an idea for further dissemination and action using these findings. Just briefly, Dr. Davida Schiff is a general academic pediatrician, addiction medicine physician, and health services researcher focused on improving care for families impacted by substance use disorder. She is the director of perinatal and family-based SUDs care at Massachusetts General Hospital, where she founded the Hope Clinic. Juliet Vasquez is a holistic focused social worker and highly experienced group facilitator who has worked with a multitude of curriculums and group settings, including DDS and DMH supported populations. Tisha Gulo is a mother of 3 children in long-term recovery from a substance use disorder. She is the lead perinatal recovery coach with the Moms Do Care grant at the Institute for Health and Recovery funded by SAMHSA, the Massachusetts Department of Public Health, and BSAS. With that, I'll turn it over to the team. Thank you.
Thank you, Molly. Thank you all so much. It is really such a treat to be here with Juliet and Tisha today to share some of our findings. Next slide. So over the next half hour or so, we're hoping to present a brief overview of perinatal opioid use disorder treatment disparities in Massachusetts. That really was the impetus for the work that we are going to present today, to describe our project aim, objectives, and methods, and then share the participant characteristics as well as key themes from the interviews that were completed. And then really this last piece, we're hoping to think with all of you about our ongoing and continuing dissemination of this work. Next slide, please. So now about 5 years ago, we were able to utilize a kind of nationally recognized database in Massachusetts called the Public Health Data Warehouse that's linked data across a number of public health data sources, including addiction treatment records, vital records, ambulance trip records, overdose information, as well as some social service utilization to really understand issues around perinatal health. And what we looked at is access to medications to treat opioid use disorder, including use of methadone and buprenorphine during pregnancy. And what we found is that in our adjusted models, there were 50 to 60% less Black and non-Hispanic and Hispanic women were 50 to 60% less likely to receive any medications to treat opioid use disorder during pregnancy. And then when you look at those that were consistently using medications, which we defined as use in the 2nd and 3rd trimester, really across the board, we have a lot of work to do for all birthing individuals, but that really strikingly, Black, non-Hispanic, and Hispanic birthing individuals were 60 to 70% less likely to receive medications compared to non-white women, compared to white women. Next slide, please. And this continued in the postpartum period. So the postpartum period among those individuals who are receiving medication to treat opioid use disorder during the month of delivery, we noticed in that 12 months postpartum that there was a significant drop-off with non-white races being more likely to discontinue medications compared to those of white race. Next slide. And so some initially said, well, that data is old. It stopped in 2015. We've done better. And so we replicated this analysis using our local individually collected at the hospital level data set through the Perinatal Neonatal Quality Improvement Network using slightly more updated data from 2017 to 2019. And we found the same thing, that when you look at the receipt of any medications to treat opioid use disorder among non-Hispanic, Black, and Hispanic birthing individuals, again, those 2 lines on the top of that forest plot, you can see that they were significantly less likely to receive medications compared to white birthing individuals. And those are really the only places with respect to any of the other either hospitalization or neonatal outcomes where we saw statistically significant differences. Next slide. And it was these findings that really led us to be able to do this work that Penguin charged us with, to really think about the drivers of disparities in care for Black and Latinx pregnant and parenting people with substance use disorder, and to do that by highlighting and promoting and prioritizing the voice of those most affected. Next slide. We thought a lot about our project approach here, and I learned a lot in thinking about how we do this really is a community-driven effort. And there were a number of kind of core aims of this project. The first was that we really work to have a community-based outreach and engagement with our key stakeholders, and focusing that on communities with Black and Latinx birthing people across the state, We identified 26 different community groups or target areas that were those that we partnered with to think about outreach as well as dissemination of this work and increase our opportunities for recruitment. We promoted individuals with lived experience as experts with an equal voice from project's inception to completion. So for an example, on an advisory board, which I'll show you the individuals who participated in the next slide, we had an equal number of individuals with lived experience as those with the sort of traditional expertise with degrees behind their name, and they were all paid the same amount to participate on that board. We trained peers who are here with us today with lived experience with substance use disorder themselves to facilitate the interviews. That in a lot of ways kind of contradicts traditional training and thinking about a qualitative interviewer as being a classically non-biased or a sort of participant observer who's removed from the actual experience of what they're studying. And we identified core program partners who could really help us think through how to best engage these patient populations in order to conduct and complete semi-structured individual interviews with birthing people of color. And we wanted to triangulate these findings, not just with key stakeholders, but also the individuals themselves. Next slide. And I won't go into this in much detail, but our team spent a lot of time thinking about these core principles and not just sort of like writing them down as a name as something that we were going to do to kind of make our project look good from a research standpoint. At each one of our individual weekly or bi-weekly research meetings, we came with a topic, an article that was really highlighting the principles of these topics to help us all, me as a white woman in this space, thinking about how I understand and really elevate the voices of individuals who are least able to be at this table, really think about public health critical race praxis, including race consciousness, intersectionality, and how to give voice to individuals, how we really do elevate and do community enhanced research, thinking about the principles of reproductive justice, which is, again, that need to both honor individuals' ability and desire to have a pregnancy, but also those individuals who choose not to have a pregnancy, and then thinking about anti-racist research methodologies. Next slide, please. And so here's our team. On the top has been our core project team, several members from the Health Policy Commission who have been really influential, who've moved on, our program partners and our peer interviewers, as well as a number of trainees and both academics and individuals with lived experience on our advisory board. With that, I'm going to turn it over to Tisha to get us started on our findings.
Thank you so much, Davida. So this is a breakdown of our study participants. We had 46 individuals express interest in the study. 6 weren't able to be reached or they declined. 5 were consented but didn't show for the interview after multiple attempts at outreach. 9 were excluded for not meeting various criteria. And ultimately 26 interviews were completed. I think it's also important to highlight that we had 1 interview that was completed in Spanish and transcribed into English. 3 interviews after being done were excluded after reviewing the content. 1 was because there was no clear indication of substance use disorder in the interview. 1, the most recent delivery was 7 years ago, and 1 was less than 10 minutes, so we didn't include it. So ultimately, we included 23 interviews for our analysis. Next slide, please. And here you can see a breakdown of sort of our participants' racial and ethnic breakdown. You can see the majority of our participants either identified as being mixed race or having more than one race or ethnicity in their background. Next sort of was participants that identified as either being Hispanic or Latinx. And lastly, our third largest participant breakdown was people who identified as being either Black or African American. And you can go on to the next slide. This is sort of a breakdown of our patient demographics. I really want to highlight some of these things while you sort of read over this slide. So first was that 100% of our participants identified as being a recipient of public payer insurance, as well as 100% of the participants were in receipt of some sort of government assistance. So whether that was through housing or SNAP benefits or anything like that. Next, I want to highlight sort of the the most common substances that were identified as being problematic for participants. So first, about 3/4 of the participants identified crack or cocaine as being problematic, either currently or in the past. 70% identified opioids as being problematic for them at some point in their lives. And about half of our participants identified alcohol as being problematic for them at some point in their lives. We can go to the next slide. So now we're going to present sort of three of the themes that we identified after going through our interviews as key findings. You can go back to the last slide. Sorry. There's just this sort of one caveat that we want to start sort of plug before we jump into going over these themes. We as a team really were really struck and impacted by going through the interviews. So as we go through them today and read some of the quotes from our participants, we really want to be trauma informed in that presentation. So we really want to encourage our audience today to take the space they need to sort of process this information. It can be really heavy. So we just want to make sure that everyone's taking care of themselves while we present these findings. You can go to the next slide now. So the first theme we identified was that participants felt that compared with white patients, they experienced increased scrutiny, mistrust, and expectations from clinicians and treatment programs. And on the next slide, I'll read a quote from one of our participants. So this 34-year-old Latina mother said, I did know a girl that was going through the same situation I was. Basically, her medication, they'd give it to her right away, nonstop during the pandemic. I would have to take drug tests and go physically into the office. I felt like it kind of was racism because she's American and I'm Spanish. I felt like, why are we getting treated differently when we're going through the same thing and we're getting help at the same place? After that, that's when I didn't really go back to receive medical care for my pregnancy because I felt like I was being judged. Next slide, please. So the second theme we identified through analysis was that participants felt they needed to more aggressively self-advocate for themselves during and after their pregnancy, including presenting themselves in ways to counteract racial and ethnic stereotypes and addiction stigma. So the next slide, I'll read another quote. So this is a quote from a mother who identified as a 33-year-old Black and Latino woman. And she said, we don't have that privilege of just being, because automatically we're being labeled as being lazy or being late or being rude. Some people will try to push our buttons just to prove that. Watch, yeah, all Black women got a temper. Now adding the addict side, oh, she's a fiend. She has ulterior motives. She's not kind. She's probably dirty. Just all those extra things that we have to work that much harder at. You're right. It is exhausting. And now for the third theme, I'll pass it over to my colleague, Julie Vett.
Thank you, Tisha. So as we just kind of continue to wrap up on these themes, the third theme here will be the substance use disorder history and gender intersection with racism to heighten and inform unique experiences of discrimination. On the next slide, I'll also be reading a quote to follow along with this. And this quote states, when my son was in the NICU, they looked at me differently. First, because I was a woman of color, and second, because I was on methadone and in recovery. You can see the difference when another parent came in. They'd be so happy interacting with them. And then when I come in, it's just like no emotion. They acted like I didn't know what I was doing with my child. They were definitely judging, and that was not right of them. I felt not comfortable and out of place. Next slide. And so these were the specific areas of inequitable perinatal care that kept coming up repeatedly throughout the interviews. And so the areas that we highlighted were, one, the inadequate pain management. This was mentioned again, right? These were repeatedly mentioned throughout the interviews from all participants, like across the board. And so unnecessary urine drug testing was the second one. The third was there was a noticeable greater chance of DCF reporting and child removal. There was reported pressure for postpartum contraception. And all participants also stated there were overt bias and discrimination from staff. Next slide. And so we have a pain management quote here, just kind of representing that domain, stating during that time, going through it after care, I didn't want to take the opioids they gave for pain because I was so scared for them to think I was really a user of opiates. I'm talking about obviously a C-section, so I'm sitting there in excruciating pain and I wouldn't take the opioids because of the situation. Next slide. A contraceptive coercion quote here states, after pregnancy, I didn't want to get the IUD, and they were very persistent of me getting the IUD. I asked about getting on birth control pills because that's what I used to do. Again, the doctors were just so persistent, and they kept coming up with why it's such a good idea and everything like that. At that point, it's just like, there's no point to argue. Next slide. So following these really poignant quotes, we really know we have to do better, right? And so action is needed for women of color affected by perinatal substance use disorders. And here we've highlighted areas where hospital-based teams can really work to implement and promote that equity, harm reduction, and that culture of safety. So I'll go through these four. And the first one is education and training of providers through an anti-racist lens to correct historical injustices. Following that, we have advocacy for patients to understand their rights and available resources. The standardization of policies to reduce room for bias and discrimination, and to redesign policies to address inequitable toxicology testing and reporting mandates. I'll be handing it back to Davida.
Thank you, guys. Next slide. So I want to highlight our efforts to both disseminate this work and then also briefly introduce you to the ongoing work of our family engagement project that we've been able to do thanks to incredible support from state opioid response funding as well as the Health Policy Commission. So we've, in consultation with the Health Policy Commission, with Jasmine Bland and team, we've really tried to narrow our dissemination to thinking about how to address clinicians and hospital-based teams, to think about how to target public health and policymakers. And then I'll show you in a later slide, really thinking about communities and individuals that have been most impacted. So some of our clinician and hospital-based team efforts that have been completed, as well as our ongoing, are the more traditional academic metrics in terms of presentation at conferences, academic manuscripts, and then the family engagement work that I'll talk to you about in our next couple slides. In terms of reaching public health and policymakers, we're really thrilled to be here today with all of you, and then have presented this at our Perinatal and Neonatal Quality Improvement Network this spring. Next slide. So just a brief intro, and we hope you'll invite us back at some point to really talk about how the Family Engagement Project work is going. But so much of what we have been able to do, Gina Liu is here, she's our lead coordinator for this project, taking a year off from Harvard Medical School to dive into this work and really think about how we support 4 to 5 hospital teams to think about integrating some of the findings that were presented to you that were really quite striking of experiences of discriminatory care that our patients are experiencing. And so I'll go through each of these 4 aims in a little bit more detail. Next slide. So the first aim that we have for our Family Engagement Project is for the hospital sites to form patient-family advisory councils of individuals with lived experience. Our goal is to keep patients at the center of QI efforts. There's been really an incredible amount of work through our Perinatal Neonatal Quality Improvement Network to improve the birthing hospital experiences, but yet too rarely are we actually getting feedback from our patients about how those quality improvement efforts are perceived, or ask them what we should be focusing on. And so our aim with this effort is to really have each hospital-based team have a patient-family advisory council that they can lean on. And inform our second aim, which is to actually collect individual family experience data with the goal of identifying areas of inequitable care through the creation of a statewide data set. by eliciting a patient experience survey that includes maternal and newborn demographic data around perinatal SUD care experiences. We're hoping to do kind of ongoing data monitoring and analysis that will allow us to stratify our data by race and ethnicity and really see how each hospital is doing and identify potential other foci for care improvement. Next slide. And then we've asked each hospital-based team to really identify a specific target area, and I'll give you two examples, one including the work that we're doing here at MGH. As Juliet shared with you, inequitable toxicology testing has been honestly described in the literature for the last 20 years and is still persists today. We've made, in response to some of kind of our clinical experiences as well as our research, we've made significant changes to our toxicology testing policy at Mass General Hospital. This is really hard to see, but if you see that dotted line, that's when we actually changed our policy to include written consent as well as very clearly outline sort of guideline concordant indications for testing. And after that, you can see a significant decrease in the amount of birthing individuals who receive testing at time of delivery. But what we're really nailing in and trying to dive into the data right now, that's again difficult to see here, but is of those who are still getting tested, our effort and our aim in kind of removing certain indications that previously were disproportionately applied to birthing individuals of color, like inadequate prenatal care or placental abruption or other medical complications, is even after removing those, we're still seeing disproportionality in the rate of toxicology testing among the women of color at our hospital. And so we have to think critically about this data now that we have it, think about how we do some staff guideline re-education to ensure guideline concordant care is being met, and thinking about opportunities for ongoing implicit bias training and examination of that toxicology policy on this ongoing way. Next slide. Our colleagues at Emerson, in terms of their hospital-specific QI work, are really interested in thinking about staff implicit bias. And so they're going to identify a panel of patients with lived experience and do perinatal staff education on perinatal and racial and ethnic disparities and work to standardize some of their clinical workflows, specifically with respect to thinking about safety huddles and plan of safe care completion. All right, next slide. And an ongoing component of this work is to just kind of feed in and incorporate the PINQUIN's continued elevation of these speak up trainings as opportunity to think about anti-racism work within the perinatal space. Next slide. So I wanted to, our sort of second to last topic before I pass it back, or last topic before I pass it back to Tisha and Juliet to end, is thinking about how we best disseminate this information to affected individuals, families, and communities. And again, this has been a learning experience for me and our team and sort of what we had proposed to all of you and where I think we end up. And that's why I'm excited to hopefully have about 10 minutes for discussion and your feedback. We spent the summer reaching out to those 26 organizations that we had sort of initially partnered with in our design and our development and our outreach to think about how we would, quote, disseminate these findings to the affected communities. And we got a pretty poor response rate. And so those individuals who engaged with us 2 years ago about thinking about how we do this work, honestly, this summer may have kind of had priority shift or may have had staffing changes or may have just been overwhelmed by this constant nonstop work that they're doing on the ground. And it left us to sort of step back and take a frame shift as to what we actually thought would be most helpful. And this is a work in progress. And so I'm sharing with you sort of incomplete work to really have you help us think through what we should do. So next slide. We had proposed initially that we would make a visual infographic. This is an example of work from another research project of mine that used qualitative interviews to understand individuals' experiences with mandated reporting as a result of prenatal substance use in Massachusetts. And by teaming up with a graphic artist, we've really been able to sort of visually depict the experience of women going through this process, right? Currently, they're in the dark, dreary woods of stress, shame, stigma, and fear, but yet we're looking towards creating a different path. And initially, we had proposed to kind of present the 3 themes that we had shared with you and come up with a graphic that would sort of summarize the findings. But where I think I'm going to propose, and where I would like for us to sort of move to, if you go to the next phase, is to still use this idea of visual imagery, of how important it is for us to capture and describe our experiences without our academic gobbledygook that goes into the manuscript, but that meets people where they're at in terms of how we tell a patient, a birthing individual who may be at risk for experiencing poor care because of the intersectional experience, their intersectional identities of being a pregnant person, a person of color, and a person with addiction, is in what are their rights. And so with respect to areas where we've identified clear lack of agency, discrimination, lack of knowledge of what actually choices they do have in terms of contraceptive choice and pain control, and a need to advocate. I mean, I think it's really was inspiring and phenomenal to go after the Beside program and hear about the ways in which doulas can sort of be that birthing advocate. What are ways that we in this perinatal substance use disorder space, where there's so much shame and stigma about being a birthing individual, really infuse that and elevate the opportunity of sort of a birth partner. With respect to the discrimination that people experience, how do we equip patients with actually the knowledge that they can decline a toxicology test, and that they have the right to know who's going to use that information and who it's going to be shared with? Specifically, again, with respect to pain control, what options do they have if people want opioid-sparing pain control treatment during pregnancy? Is that being offered to them, and how is it being discussed? And then really thinking about shared decision-making with respect to contraceptive choice. I'm really hopeful that we're going to see change in our legislative statute around mandated reporting that disproportionately and discriminatorily impacts women in recovery taking medications to treat their opioid use disorder, which I think is also leading to some of the poor outcomes that we're seeing. But how do we have patients inform that advocacy change, and then work with legislative and policymakers to sort of ensure that new change is enacted in a way that really meets their needs. So with all of that, I'm going to pass it back to Tisha and Juliet to end and root ourselves back with our patient stories. Next slide, which is really the most important part of this work.
Thank you so much, Davida. And yeah, I think for myself and Juliet and Davida, we really wanted to end on this note, sharing 2 quotes from our participants, because I think for us, this study really was about elevating and hearing the voices of the folks that we interviewed. So I'll read the first quote, and then Juliet will end us with the second quote. So this quote says, "When DCF took my kids is when I became sober, because my kids shouldn't have to go through that. My kids are African-American and they're Latino, and they're going through shit at the age of 15, 14, and 2, and they're not white. So that's what it is. And it hurts. It hurts me. I'm watching a lot of white people whose kids get that and this. As minorities, we've got to pull and keep pulling and fighting. That's not fair. You feel like you're doing the right thing and you're still not doing the right thing."
I'm accomplishing a lot. Like I said, it's not easy being a Latina and not getting the proper help we need because they don't want to help us. They want to help the Caucasians, and I don't think that's fair how they treat us minorities. We're not getting no proper help. We've got to fight for our own and use our own words just to get what we need. I mean, nowadays, it's even hard to go to the hospital without them judging us. Yeah, that's my story.
We'd love to open it up to all of you for any questions or comments. Thank you.
I think we're all trying to catch our breath. Are there questions or comments?
Yes. Well, first of all, just thank you so much for that excellent and powerful and informative presentation, and for the research that you're doing and for your approach to the research. Just a round of applause for that. So I guess I have less of a question at this point, but really more of a comment. And my comment is just that for me, it's heartbreaking to see that marginalized pregnant individuals are being surveilled, during pregnancy with respect to the toxicology test, but at the same time being underserved, for example, in terms of pain management, and also very heartbreaking to see the extent to which patients perceived or recognized that there was a way in which perhaps they were being coerced into contraceptives after delivery. So there are the literature on this goes back a long way, as Dr. Schiff mentioned, and it just reminded me of Dorothy Roberts' work, which really touches on this issue quite a bit. So I guess no huge questions at this point. Actually, I do have one question since there's time. My question is about the Speak Up training. I hadn't heard of the Speak Up training before, so I was just wondering whether that's sort of the principal intervention that would be used, or are there other trainings that might go along with it? And is the Speak Up training designed to kind of speak to that intersection of folks who are struggling with substance use disorders or substance misuse? And yeah, that's my question for now.
Thank you for sort of framing the totality of our findings in the context of the historical structural racism that our society has perpetuated, and for your question. I was just in the process of seeing if I can, I'll just put into the chat the link for the Speak Up training to see more. They are a really wonderful team that are doing these trainings now across the country, but actually I think initially did launch much of their work here in Massachusetts, and our Perinatal Neonatal Quality Improvement Network team has partnered with them to really think about this in the context of the birthing experience for women of color. There are, I have not participated in the training myself, I should. Some of our team members, Doula and Gina, are going to participate in it later on this month, and there's another one that's coming up in November. So there's a couple that are coming up soon in Massachusetts. But my understanding is that there are elements of experiences around individuals with substance use disorder that are part of the training, although it's not a focus. With respect to the second part of your question of sort of, is this going to be the main intervention? We're really trying to let hospital-based teams lead and see what their identified need and focus is. At the state level, the Speak Up trainings have been what PinQuin has promoted as a hope that hospital-based teams, and I think there's been like almost, well, you might know these numbers, like 3/4 of hospital-based teams have actually participated in them, in the Speak Up trainings across the state, and they have an aim of trying to hit all of the birthing hospitals at some point.
Thank you. I also had a question as well as a comment, and it is heartbreaking to see those quotes, and it speaks to a calamitous, in my opinion, lack of knowledge, experience, and training for our clinicians. My question is there any way of knowing, given the experiences that your participants had, how many of the clinicians involved in the care that generated those comments are older clinicians versus younger clinicians, faculty versus students, faculty versus residents? I'm looking to see if there's any hope of aging out of these existing perceptions. I think I know what the answer is, but I'm asking the question.
I mean, I can kind of speak to some of like my experience doing the interviews. I think that a lot of the themes throughout a lot of the interviews that I did had to do with nursing in particular, and sort of negative experiences with nursing. And also, though, on the flip side, some of the most positive experiences that folks described also had to do with nursing. There was a real lack of description or talk about sort of like provider or doctor like interaction. And I can't recall, and Juliet, if you heard different in your interviews, there was no sort of talk about like the demographics of like who they were getting care from.
Okay. Yeah, I asked, and the question, the answer to that is an obvious response of how do we take everybody who's providing care and lead them towards the kind of care that people need. Obviously, the more clinicians we have who represent the people they're caring for is critical, not only in terms of the comfort of our patients, but the ability to teach their colleagues who are not. That partnership of clinicians who look like patients and clinicians who do not, and the ability side by side to learn from each other is critical. So it's not only addressing the things that are in our environment to address, but it's also asking our academic institutions to actively seek out and recruit students who reflect our population. It's a big ask, but it's an extraordinarily necessary ask. And I guess I'm being more philosophical than problem solving, but I want to thank you all for your work and for bringing at a very I guess gut-wrenching level this experience, because I think only by doing it, by bringing it at a gut level, do we demand the attention of those out there and responsible for helping solve this, that we grab their attention. We say it is not acceptable to leave this as it is. And I think those stories are powerful. I thank you for sharing them, and I encourage you to continue to. Oh, Dr. Castile, I'm sorry. I got so into my own stuff, I didn't see your hand. My apologies.
So Barbara, I was going to start by.
Before you go, sorry, I think Juliet was going to come off mute for just one quick second. Maddie, if that's okay.
Okay, thank you.
Juliet, please.
Sorry, yeah, I just wanted to add along with what's already been said in regards to that, in terms of like my interviews and some of the things that I've seen or heard. I think exactly what you were saying in terms of, just everyone, right, providing that support and that training, that education to everyone. I heard stories all the way from schedulers, right, for urinalysis testing, receptionists when they're coming in to check in for appointments, right? So everyone kind of deserves that trauma-informed approach training and education to be able to provide that care. So even thinking about, just folks who may not have clinical or medical kind of interactions with clients, but really just any, from the outside in, right? Really supporting the folks. And there were some commentary made depending on the client's experience, not only with hospital sites of care, but also regular, I guess it would be still considered a site of care, but like OBGYNs, right? Or, drop-in clinics where they're looking for information. They're not engaged with a PCP or any other kind of provider at the time. So even those spaces also were kind of like mentioned throughout my interactions with folks.
Thank you for that, Juliet. Maddie.
So Barbara, I can go on and on, but you talked about the older docs. I'm one of those older docs, and and so it goes across the board. But I do treat and mostly men with addiction, and the and Latino men with addiction, and across the board, the amount of racism that you see throughout the entire healthcare system. And also very familiar with Moms Do Care here in Worcester. I think everything you described is what people are experiencing here. And certainly some of the issues regarding, the medication treatment, and then the further pieces of people who've been sober for, 5 years, whatever, that they still go on to be reported to DCF and have that as an evaluation, having them go to their homes, go to where they work, or go where their kids are in school, is the most demeaning thing that can happen. And it's some archaic policy that we have in place, whether it's a policy or whether physicians are uncomfortable or whatever it is, right? It's a process that happens in the hospital. And I guess one of my comments regarding that, and by the way, I do want to say that I loved your entire presentation, and it certainly rings with me. I think I always sit there and think about all the other things that we can do. And I guess when we do this DCF reporting, because we don't know, she's got a substance in her body, even though we know the substance is Suboxone, right? The medication that the person needs to remain sober. But that we then don't supply those services when somebody leaves the hospital. So we have recovery coaches that are there, that are helping, but they don't leave the hospital. And so when we're talking about helping someone with substance use, one of the main things that we talk about here is where's their support system and who's going to follow them through that process and make sure, whether it's a recovery coach that's going to follow them at home and make sure that they're okay. Thinking about the hardest time for someone when they deliver is truly taking the baby home and taking care of the baby, whether you're a single mom or not. And that's where the support is needed. And we don't do that. We give the support in the hospital, which is great. But how do we push to be able to give that support outside the hospital? For most of us who've had kids, we know that it's difficult to raise kids. And so how do you give that support to women in recovery during that time? So those are some of the things that we're trying to look at. How do we do that? Mm-hmm. But overall, I think that the treatment of anybody with substance use, and in particular people of color with substance use, is incredible. And nobody, to this day, we talk about forever that it's a disease process, and we have people who don't believe it's a disease process, docs who don't believe it's a disease process. Certainly our whole justice system, all of that doesn't, and that's years of trauma that people have gone through. So how do we support them, I guess, is a lot of my questions and thoughts.
Okay. Thank you, Maddie. And I know we're over time. We had done a Herculean job of not going over time. And one of the things I just want to say to the folks who are presenting, it is frustrating to me, and I'm sure it might be frustrating to you, that all the effort and the work you put into what you've done, and you come here to tell us about it, and we give you such a short period of time. It is frustrating to us as well, but we appreciate the work that you do, and the work that you do informs us with regards to policy. It informs us with regards to recommendations to the legislature. It is one of our primary responsibilities to advise the legislature on innovation and innovative work. And so please know that your presentation here today goes further than your presentation here today. I want to thank you all so very much for the work that you do. It's hard work, and we are going to ask you to continue to do it. And thank you for the effort. Thank you for your leadership. And we look forward to continuing to hear from you as you continue to work to get this information out to everybody. So thank you all very, very much. This is a very impactful program, and we acknowledge that with you. So with that, Kelly, I don't know that we have anything else. David's smiling. He is okay. We've done our job. smile. So if we are done, I think we're done. Thank you all very much for your time today. Take good care.